Good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I am your chairman, Jocelyn Peña-Melnick. My vice chair is right here, Giovanni Callison. We're joined by Attorney Lisa Simpson to my right. I'm going to go through some of the rules. I kindly ask for your patience if we encounter any technical or streaming issues. I want to welcome everyone to the Health and Government Operations Committee. Those that are here and those that are at home, thank you for joining us today. I want to thank this amazing committee for being on time and for really working so hard, and people do not know that, how hard you worked. It is not only the hearings, it's all the emails and the people that visit you. I know I have about 10 meetings a day, back to back, and I know you guys have them as well. And this is great because our constituents are coming to give us their perspective on different bills, right? So thank you for the work you do and the work you're about to do, because we're gonna have very long days, more bill hearings as well. As a reminder, there's no food or drink allowed in the gallery. That's because our staff doesn't have the time to clean. You will see that we do drink, but that's because we sit here for hours, right? And we have to stay hydrated. For each bill, this is the way it's going to work. We are going to hear from the bill sponsor, the person that is introducing the bill. In this committee, we do not time the bill sponsor, but we know that the bill sponsor is actually going to try to be respectful and not abuse that time. Anyone else that testifies, a witness only gets 2 minutes. So, and it's going to be favorable with amendment, and unfavorable. If I have a lot of unfavorables on a bill and I have one person that is, a lot of favorable on a bill and one person that is unfavorable, I try to take a pause and bring that testimony so that it can be balanced as well. The witnesses here get 2 minutes to present their testimony, and there is a timer that is displayed on the screen. And the witness panel, you will see it will sound when the time has expired. I'm not going to be rude, but I do ask you to be respectful and finish up your thought, please. And for our wonderful committee, please adhere to our usual committee rules of one question and one answer, and please keep your questions brief. As you know, these bills are assigned to subcommittee where we do the work, and you'll get to ask people, the sponsors and the advocates, more questions, and also we do that online as well and by phone and email. Members of the public will be able to view the live stream. They're watching it right now on the Maryland General Assembly website and YouTube. And as a reminder, we have something amazing this year, which is these closed caption. And it came out of this committee because we had a person that was deaf mute, and we didn't have that. This year, I want to thank leadership for implementing this. However, what happens is that it can pick up side conversations. So if you don't want us to hear it, or the whole of the world out there, do not say it, okay? Today, we're going to hear the bills in the following order. But I do want you to realize that I may change the order because sometimes the witnesses, the sponsors are in other committees and they have bills, and I need to be flexible, all right? So I would like you to give me that grace. We're going to start today with House Bill 381, and if you wonder how does she decide the bill order, it depends on the number of witnesses, right? So if you have one witness, you shouldn't be waiting when someone has a bill that has 20 witnesses, right? So 381 only has 2 witnesses. We're going to start with that. 406 has 4 witnesses. We're going to go with that. Then 297 have 5 witnesses. 256, 10 witnesses. 382, 11 witnesses. 383, 11 witnesses. And the last bill of the day, House Bill 11, has 16 witnesses. So that's how we're going to do it. However, keep in mind that I may move it. So House Bill 381, Delegate Martinez, Maryland Medical Assistance Program and health insurance require coverage for aesthetic services and restorative care for victims of domestic violence, also known as Healing Our Scars Act. Will you be so kind and bring your panel? And good afternoon.
Thank you so much, Madam Chair.
Good afternoon.
Thank you, thank you. So, good afternoon, Madam Chair, Vice Chair, and colleagues on the House Health and Government Operations Committee. I am Delegate Ashanti Martinez, here to present House Bill 381, Maryland Medical Assistance Program and Health Insurance Required Coverage for Aesthetic Services and Restorative Care for Victims of Domestic Violence, or what we like to call Healing Our Scars Act. House Bill 381 requires the Maryland Medical Assistance Program, as well as other insurers, nonprofit health plans, health maintenance organizations, and managed care organizations to provide coverage for aesthetic services and restorative care for victims of domestic violence. This legislation aims to ensure that domestic violence survivors have access to necessary treatments for their physical recovery. What we know is that domestic violence is pervasive and deeply damages the people all around the country. According to the Center of Disease Control and Prevention, approximately 41% of women and 26% of men experience sexual violence, physical violence, or stalking by an intimate partner during their lifetime. While many organizations work tirelessly to prevent future abuse and protect survivors, it is equally important that we focus on helping to heal the physical and emotional scars left behind. These physical scars serve as consistent and painful reminders of the trauma that they have endured, specifically impacting their quality of life and ability to move forward. The Healing Our Scars Act aims to address these needs by ensuring that survivors have access to restorative care. And this is not a new approach. It's proven. An impactful solution has already been demonstrated in its effectiveness by helping survivors rebuild their lives through philanthropic programs such as the American Academy of Facial Plastic and Reconstructive Surgery Foundation, who, working with the National Domestic Violence Project since 1994, have been providing facial injury victims reconstructive surgery for the last 2 decades. What we want to do is replicate these programs and follow states like Illinois, who are providing this coverage already. By mandating coverage for aesthetic and reconstructive care for victims of domestic violence, we are telling survivors of domestic violence that not only we care for them, but that their care is going to be medically necessary. And so I really appreciate who I have on the sponsor panel, my good friend, Councilmember Crystal Oyata from the Prince George's County Council, for coming to me with this idea. That's one of the reasons why I'm championing it, because there's so many Marylanders like her who would benefit from a program such as this. In your package, you will find a letter of information from the health department. I'm working tirelessly with them to try to get this as cost neutral as possible. I'm very well aware of what the budget is. I'm very well aware of what our financial situation is, but I'm also aware that we don't protect survivors the way we should, and we often leave victims on the hook for their repair. And so I think it's time that we really focus on how we can improve the lives of victims here in Maryland. We talk a lot about crime, those that commit it. This is an opportunity for us to do something for victims. And so I'm really appreciative of your time, Madam Chair and committee, and I ask for a favorable review of House Bill 381.
Thank you. Councilwoman, how are you?
I'm good.
Good to see you.
Good to see you.
Is that the baby in the back?
Yes, that's my little
He's so beautiful. Beautiful.
I know. He'll steal the show. Oh yeah, come give me some both. Oh, I'm sorry.
That's okay.
It's okay.
You're not gonna come get me.
It's okay. What is his name?
It's Ezra.
It's beautiful.
Thank you.
Well, welcome to the Health and Government Operations Committee.
Thank you so much. One, I want to thank the sponsor of this legislation, not only for being an advocate for survivors, but for holding my hand through probably one of the worst times of my life. I am a council member in Prince George's County and have the honor of serving in that capacity. But I'm here today not as an elected official, but as a survivor, because this is my story. It was inspired by lived experience. I was in a domestic violence marriage for over a decade where I experienced both physical and mental abuse. One of those instances where I was pushed down the stairs left a scar. Like so many survivors, I didn't go to the hospital in time. So it left scar tissue that cannot be fixed without surgery. And this is not a story that's special to me. I've talked to domestic violence survivors, one woman in particular where her abuser left her mouth riddled without teeth. And so as she was surviving and healing and getting whole, it took her a decade to save the money to get the repairs that she needed. So for a decade, her abuser continued to take her joy and her laughter and her smile because she was continuously reminded of what she suffered. I too have that moment every day when I get up. You saw my little boy, who I love. I'm married to the most amazing man, and I feel completely healed and whole. But there's one moment in every day where I get up and I take a shower and I look in the mirror. And the abuser has one moment to take back my power. And there's no way for me to fully heal and for so many survivors to heal until they can have every ounce of their power back. And so we cannot only think about the mental trauma and support that they need, but making sure that when they look at the mirror, they no longer see the abuser and what happened to them, that they have the ability to heal fully. So I ask you to support this legislation and to stand with so many survivors across the state of Maryland that are trying to heal themselves and move forward. Thank you.
Thank you for sharing your story. You know, in this committee, we certainly appreciate it. It takes a lot to open up and share personal things, and I want you to know when you leave here that, you know, we do not take it for granted, okay? So thank you for being here. I'm gonna open it up for questions now. Are there any questions for the sponsor and his panel? I see Delegate Hill followed by Delegate Kaiser.
Thank you. And thank you for sharing your story. Thank you for being a survivor. And I'm sorry for what you lived through. I would like to, full disclosure, I'm a plastic surgeon, okay? And take Medicare, Medicaid patients. Generally, when we are billing for services, we write down the diagnosis, so missing teeth, fracture, scar, keloid, whatever it is, and sometimes we list the cause, auto accident, shooting, whatever. Assaults are assaults, whether they're domestic violence or not. So I'm a little confused specifically about what is not covered that you would like to see covered, because generally injuries resulting from assaults or accidents are covered. So what is missing that this would take care of?
Yeah, that's a great question. So one of the things I've been trying to work with the department is how to cover folks that don't get seen immediately. Like the times that you mentioned around assault oftentimes come with like a police report or something that individuals can bring immediately that you can then write for the cause. For folks that are in silence or trying to hide their scars and now are given the ability through this bill to come to you, this would allow for you to say this is medically necessary to remove those scars. And so there's a cost to that, right? Because the federal folks don't match the funds. And so that's what we're trying to figure out is how fully can we get this bill to be cost neutral as much as possible, and what we might have to do on a Healing Our Scars Part 2. And so the department is working with me on amendments to make sure that happens.
And I'd be happy to take it offline, but for instance, if you come with a scar that's a result of an injury from 2 years ago, there's a code that says sequela. And so I would bill it as a scar due to a car accident, due to an assault, due to whatever, sequela, late effect sequela, and that would generally be covered.
Okay, well, you are also a practitioner, so I would love your insight.
Thank you. Delegate Kaiser.
Thank you, Madam Chair. I'm trying to find the testimony. Delegate Martinez, first, council member, thank you for coming today, and thank you for sharing your story and putting a human face on this. Delegate, my question for you, I wanted to give you a chance to react to the one piece of opposition testimony.
Yes.
From the League of Life and Health Insurance, because they did not sign up for oral testimony, and they would reference that this particular legislation raises many questions, including how to determine who a victim is and why the perpetrator of the violence is not responsible for the aesthetic coverage. So I wanted to give you a chance to address the statement they made.
Yeah, so I did send Matt the bill ahead of time. I would have loved if we were able to find a time to communicate before the hearing. I did also read the letter and saw that as well. I think that's one way you can slice this, right? Is to try to say, well, maybe the perpetrator of the violence should be able to cover the costs. That's just not the way we approached it, particularly because not everyone who is a survivor goes through a court system for their, adjudication. A lot of times, because of who their assailer is, they rather just get away. We have a lot of people who don't have the opportunity to get justice, and this is a way I think that we can encompass victims' ability to do that. And so, I wish everyone had the luxury of going to court, but a lot of folks don't.
But thank you. And if I may follow on that line of questioning, even when you go to court and there's a judgment issue, it doesn't mean you can collect.
Of course.
And the court process sometimes takes what? Forever, right? And then for you to go after a person in a judgment, you have to see if they're working. Where do they work? And can you garner their wages? Because they're not going to easily give you a check, correct?
Absolutely.
Are there any questions? Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. So the victims that don't go to court, how do they then later, what are the requirements to show it was from domestic violence, or what would they have to show that it was from a domestic violence situation?
Yeah, so of course they would have the scar. That's an immediate evidence that something did happen. I don't like to put people through hurdles and hoops to kind of justify their stories. I know we're talking about state money. We want to make sure that we're spending this correctly, but I find it challenging to think that there would be a massive use of abuse or overuse of this for some type of scar removal. I think ultimately those that might not have a police report still have a story, still have an opportunity to share that with their practitioner, and then it was ultimately up to them and their doctor about what is going to be deemed medically necessary. And so I think that's the conversation that would happen within that space. I mean, because under the bill, if you look through some more of the testimony that was provided, there's some expansions of the definition of domestic violence that we can also look at, that I know that some victims groups would like, that we're exploring and talking about as well. Part of what we did was mimic Illinois' bill with a very kind of strict guideline around what domestic violence is. And as long as you are under that definition, then you get the coverage. And so if you have a mechanism that you think might work as a check, I'm also all ears.
One follow-up, Madam Chair. Do you know if there's any requirements in Medicaid when you go in for something like that of proof?
I can follow up. I'm not sure.
Okay.
Yeah.
Thank you. Mm-hmm. Thank you, Madam Chair.
Any other? Delegate Woods, followed by Bandari.
Thank you, Madam Chair. Also, thank you, Councilwoman Oriada. So good to see you here, and your mother, and Ezra. Mm-hmm. And Ezra is named after her father. I just have to tell you all of that. Who's a wonderful person also. Thank you also, Delegate Martinez. I wanted to get some clarity. So it's actually the doctor who is giving the justification, is that correct? So
yeah.
It's based on the doctors, saying, yes, I want to confirm that this is what is caused, that this was caused by domestic violence. Is that correct?
So let me go to bill language, because I don't want to lie to you, Delegate. This is bill language here. Okay. Yes, so it's under the insurance article, page, I think 3, and it is under 15-81. It is under C number 2. It's determined to be medically necessary by a physician who is licensed to practice medicine under the health occupation articles. And then it goes on in the bill to determine how we define what victim of domestic violence is.
Thank you.
Yep.
Bandari.
Thank you, Madam Chair.
You're welcome.
And thank you, Delegate Martinez, for the bill, and thank you, Councilwoman, for advocating the bill. Recently, a domestic violence incident in my district in Rosedale underscored this urgency of this bill, and I seriously think that survivors should not have to live with untreated physical scars due to the lack of coverage And just, I don't have a question, but this is a very timely bill, and thank you so much.
I appreciate that, Delegate. Thank you.
Agno.
Thank you, Madam Chair, and thank you for bringing this legislation. I just wanted to ask you, while you were here, if you've seen the recommended amendment to replace physician who is licensed with healthcare practitioner who is licensed, certified, or otherwise authorized to practice under the health occupations article. And I think there's another recommendation that includes dentists or maybe healthcare practitioners capturing all that. But is that something that you're looking at, and is that also something you're talking with the health department as you're looking at cost neutrality?
Yes and yes. And the reason why we're looking at it is because if we were to add dentists, that, of course, puts the price up. Unfortunately, all the good bills have price tags. And so it's one of those things where, that's part of the reason why we don't cover it, the cost. And so looking at how to be cost neutral for this year is what we're focused on. But that doesn't mean that we won't be back, year after next or whenever we have a little bit more of a bigger purse to be able to add and provide for what we left out. But we definitely are aware of the expansion of definition, just because we know sometimes the level of care that you're able to receive depends on, your income level, where you live in the state, and being able to really be able to get to someone is really important. And so we're looking at all angles of this, but cost is the number one priority.
Thank you. Thank you, Madam Chair.
You're welcome. Any other questions? Seeing none, as you know, we have a fiscal, challenge.
Of course.
So if you can please try to work it out with the department, and I know you're doing it already, so
Yeah.
I'm preaching to the choir, because you do really great work. That would be great. Also, I know that my friend Matt is in the audience, and if I can ask my friend to meet with you as well, that would be great, okay?
He's my friend too.
I know. Thank you. Thank you. Okay, this actually concludes the bill hearing on House Bill 381. And next, we're going to House Bill 406, and that is our wonderful Delegate Gazzoni. And the title is State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologist, and Music Therapist, Appointment of Members and Quorum. Good afternoon.
Good afternoon.
How are you?
Good.
Good?
We're doing great over here.
Okay.
It's a sunny day.
And if you both ladies will be so kind and move the microphone closer to you, Delegate White Holland will really appreciate it. It's a private joke between she and I.
So good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. I am Delegate Pam Gazzoni, representing Howard County's District 13, and I am here in support of House Bill 406. This bill, which the department asked me to introduce, modifies in two ways the statute governing the State Board of Examiners for audiologists, hearing aid dispensers, speech-language pathologists, and musical therapists. First, the bill eliminates the role of professional organizations and associations from the board's appointment process. Currently, there is inconsistency in the appointment process. Professional associations are part of the process for some, but not all of the professions included on the board. Eliminating the role of associations will not only increase consistency in how individuals from the professions apply to the board, but it will also support a broader and more equitable pool of qualified applicants. With this change, the board will directly notify all licensed practitioners of vacancies and solicit nominations for submission to the Secretary of Health and the Governor, rather than submitting nominations from an association-provided list. Second, HB 406 will modify the requirement for what constitutes a quorum. The current statute requires a quorum to include at least one representative from each of the disciplines, again, an audiologist, a hearing aid dispenser, speech-language pathologist, and a musical therapist. This requirement frequently causes delays in addressing key issues, since if a representative from one discipline is not available, there's no quorum and no official business can be conducted. The bill amends the quorum requirement to a majority of the appointed members of the board being in attendance. These proposed changes reflect the evolving needs of the board and practitioners, allowing it to function more effectively while promoting equity and inclusivity in the appointment process. I respectfully request a favorable report on HB 406. Thank you. You're welcome.
Good afternoon.
Good afternoon.
How are you?
I'm fine, thank you. So my board is in full support of HB 406, and just to reiterate the reasons that our delegate has brought before you, the most important factor is consistency amongst the disciplines of the board. The board currently serves 4 disciplines, with the largest discipline being selected by the board and the smaller disciplines going through an organization. This does cause a problem as far as quorum and different type of business matters are concerned. In fact, it does ensure a delay in placement of appropriate board members. Removing the organizations from the appointments process, I feel myself and the board feels would create a more equitable process as far as being more attractive to other applicants that may not be a member of a paid organization. A good example that I would like to provide you with is I currently, in a particular discipline, each of our disciplines is represented by 3 individuals. I am down to 1 individual in a particular discipline for this reason alone. I cannot fill those slots because we are waiting for organization appointment. However, that organization has disbanded. So I am really at a crossroads because I have these disciplines that I can't fill, which would, of course, put me in danger of not making quorum. And of course, that puts us in danger of not being able to conduct business appropriately. As far as our quorum component, with most boards in the state, a quorum is defined as a majority of your board members. We do, of course, have that requirement with the added point of being a representative from each discipline. There have been times where meetings are delayed or have to be postponed because we do not have the appropriate representation. We always have the number of members available, but maybe not from each discipline. And as I stated before, for example, I have a discipline that I am down to 1 board member. So if unfortunately that person gets sick or cannot make the meeting, then that can push us back in business for a month. So with all that being considered, I do request a favorable report on HB 406.
Thank you for the work you do, okay?
Thank you.
Really appreciate it. I'm going to open it. Actually, there's another person, Carrie DeSantis, no?
That's my chief of staff.
Okay, great.
She just submitted it for me.
Okay, good. All right.
Thank you.
So let's open it up for questions. Are there any questions? Delegate Kerr, followed by Kaiser.
Thank you, Madam Chair.
My pleasure.
Ms. Stevenson,
Hello.
looking at your HGO 406, and it has a very similar title to my bill of last year, HGO 407.
Yes.
It's under Section 202.5.1. My bill put in the words Maryland Academy of Audiology. If I look at your bill, same section, Maryland Academy of Audiology is removed and the board is put back in. So essentially, aside from the quorum piece, what this legislation does is undoes what we did last year that passed the committee unanimously and passed the House unanimously. Now, we heard testimony last year about a lack of responsiveness, a lack of expediency, a lack of action on the part of the Board of Examiners to send the names forward to get the board members appointed. And that was the impetus behind requesting this change. One more point I'd like to make is that most boards are moving in the direction of making direct appointments to the governor, whereas this change seems to be taking us backwards. So I guess my question is, what has changed in the last year that addresses this lack of responsiveness, lack of expediency, lack of action on the part of the board, that the Maryland Academy of Audiology can be assured that they're going to get some attention?
So I would say one thing that probably is different from when the original bill was introduced is a full staff that can help out with administrative matters and the board. But the Maryland Academy of Audiology, I want that to be very clear that that's not, the particular organization that is targeted. There are no targeted organizations. This is being requested simply so that we are permitted to move names forward and not have to wait for an organization to do so.
But you previously had the ability to move the names forward. So I think what you're asking to do is go back to what we had before, which wasn't working.
Well, we are not fully in charge of appointments. We do move the names forward. The public is notified of any vacancies that goes through the appointment office. The final appointments are made through the appointments office. All that we do is the submission, and the organizations that are listed also do the submissions. It is actually out of our hands from that point.
Thank you, Madam Chair.
Kaiser.
Thank you, Madam Chair. After hearing Delegate Kerr's question, I realize he knows a lot more about this than I do. The question I wanted to ask was, I heard you mentioning the organizational challenges. I heard you mentioning the challenges with a quorum. And I guess I was concerned that if a board is appointing its own members, even from different sources, even with the governor selecting among a list of names, the board can self-replicate a point of view that maybe isn't always helpful to a board's membership. So I guess I was trying to understand why we're putting it in the board's hands, because I think that diversity of viewpoints is incredibly valuable, and that a board is more likely to choose people that are like them in philosophy. So could you address that?
Absolutely. And as far as viewpoints, I think that is a good reason why the board does wish to maybe eliminate organizations. You know, there could be the assumption that if you're not a member of the organization, your name will not be put forth. So, you know, I think we're kind of saying the same things. That is the reality of the board, and the hope of the board is to offer any qualified individual, you know, the option to apply for the board. However, right now, I mean, quite frankly, I don't think that if you are not a member of a listed organization, your name is going to be put forth. I think that's a fair assumption, and that is what the board is trying to eliminate. You know, the full desire is to have the largest possible selection pool available, you know, for when those names go to the Office of Appointments, so they have a wide and broad, you know, pool to select from.
You're welcome. Vice Chair Collison.
Thank you, Madam Chair, and thank you. I guess I was thinking along the same lines as Delegate Kaiser, but I guess I'm still puzzled. I hear you say you're making the assumption that people who are not members of these societies don't put their names forward.
I'm sorry, can you repeat that last part? I'm sorry.
I feel like you're making the assumption that people who are not members of their professional society are not putting their names forward because they don't think they would be considered. I guess if the, and as Delegate Kerr said, we were having the problem before where not enough people were putting their names forward, so I'm not sure how this changes that.
So just to be clear, anyone can put their name forward. Anyone can apply, you know, to an appointments board.
Right.
So as long as you're in that portal, your information is in there and that goes amongst the pool. However, where the organization is involved, for instance, if I am a non-organizational member, I put my CV in the system. My CV is in the appointment system. However, if I'm not a member of a certain organization, I'm probably, regardless whether I'm in the system or not, I'm probably not going to be considered because I'm not one of their members. So again, it's just about giving everyone a chance. We cannot personally select everyone. It's not a personal pick. We do encourage, for instance, when it is time for new member appointments, a mass email goes out. That email goes out to the 6,100 licensees that we have. It's somewhere around that number, somewhere between 6,100 and 6,200 licensees that we have. That is not exclusive to anyone in particular or to anyone belonging or not belonging toward an organization. Everyone that we license in the state of Maryland receives that email and is encouraged to apply. However, even after applying, we cannot guarantee that your name, you know, will be put forward. For the discipline that the board does have, I don't like the word to use control, but for that we have, I guess, a say in, if you would. All of the applicants, we forward all of those applicants to the appointments office to make that choice. And some of those are members of associations and some of those are not. You know, we can't tell, you know, that's not what we're looking at. We're just looking to make sure that, you know, you meet the qualifications and then our appointments board, because the appointments board actually does make that final selection. We're pretty much just trying to make sure that everyone gets looked at least.
May I follow up, Madam Chair? So I'm still not exactly clear, and I'm sorry if I'm being
That's okay.
dense. I'm not hearing you say that the organization determines the list. Is that the case, that the organization determines which names go forward?
Yes, yes.
Okay, so.
For certain disciplines, yes.
Okay, but not for all.
Not for all. And if I could just back up a little bit, that's kind of a reasoning for this bill. It really kind of should be an all for one. I don't, the board does not feel that we should do one thing for one discipline and another thing for another discipline. I think consistency is important, especially when you're a multidiscipline board. You know, it is about, you know, equal opportunity for everyone.
Okay, I guess I would like to perhaps work with you a little on figuring out if there's a way to meet the needs of both interests here.
Yeah.
In terms of making sure your board is full and robust and with, but also with a variety of viewpoints and perspectives. So I think I'm thinking there might be ways to do that. We can take this offline.
Absolutely.
Well, in handling the questions, thank you so much.
Thank you.
Any other questions? All right, seeing none, I just want to say, and I know the sponsor really well, and she's very thorough. If those on the committee that have questions, please continue to work on it. Thank you so much for your time, and for being so patient as we ask the questions, okay?
Absolutely. Thank you very much for your time.
You're welcome. We have a virtual witness, and it's an unfavorable, is Dr. Melissa Seged. Will you be so kind and bring that person up? Thank you. Dr. Melissa Seged, will you be so kind and bring that person up? Thank you. I do not want to hear my voice.
Hi, can you hear me okay?
Yes, we can. How are you?
Thank you. Okay. Madam Chair Pena-Melnick, Vice Chair Collison, and committee.
Second, will you be so kind and bring that person up? Okay. Will you be so kind and mute if you have the channel? Yes, we can. How are you? Get off of that?
Thank you. Oh gosh, I know.
Please. It's okay. Don't worry about it.
Listen, and committee.
Second, will you be so kind and bring that person up? It's a very nice voice. No, just kidding.
I think I did it. Did it go away?
It's okay. Yes.
I'm sorry.
Don't worry about it. It happens, okay?
I was hearing myself twice. It was panic. All right.
It's okay. Take a deep breath.
Thank you. Let's start over.
Okay. It's okay. Go ahead.
Madam Chair Pena-Melnick, Vice Chair Collison, and committee members. My name is Melissa Segev, and I am a second-generation licensed audiologist and small business owner of one of the largest and oldest private practices in the state of Maryland. On behalf of the Maryland Academy of on behalf of the Maryland Academy of Audiology, I am here to oppose HB 406. The Board of Examiners for audiologists, hearing aid dispensers, speech-language pathologists, and music therapists consists of multiple professions. The hearing aid dispensers, music therapists, and physicians all nominate candidates for vacant board seats from the state professional associations. Successful legislation in 2024 from Delegate Kerr now requires the Maryland Academy of Audiology to submit candidates for vacant seats. The legislation became effective October 1st, 2024, and therefore will take effect of spring 2025 this year for the opportunity for MAA to officially submit nominations. HB 406 would revert the successful 2024 legislation without allowing it to take effect. Additionally, HB 406 does not align the Board of Examiners for Audiologists with other Maryland health occupational boards, including chiropractors, social work, optometrists, nursing, and many more who all submit names from state professional associations. HB 406 would further alienate the Board of Examiners for Audiologists from other state boards. Therefore, I ask for an unfavorable committee report on HB 406. Thank you.
For this witness. Seeing none, thank you so much for being with us. And this actually concludes, you're welcome. This actually concludes the real hearing on House Bill 406. Have a wonderful day.
Thank you.
You're welcome. Next, we have House Bill 297, and that is Delegate Kerr, Maryland Health Benefit Exchange State-Based Young Adult Health Insurance Subsidies Pilot Program, Sunset Repeal. Will you be so kind and bring your witnesses as well? Thank you. And we're making good timing. We're doing well. And while he comes, I want to thank the staff for your work, okay? And keeping us running like a good oil machine.
And we have a panel witness virtual as well.
Okay, wonderful.
Well, good afternoon.
Good afternoon.
Let me get this out here. This is House Bill 297, and we're talking about the Maryland Health Benefit Exchange.
Kerr, and put the mic closer to you.
Okay, I'll start over.
Yeah, Delegate White Holland would like it closer.
Good afternoon, Delegate White Holland. Good afternoon, Madam Chair and the committee. I'm Delegate Ken Kerr. Here today we're talking about House Bill 297, which we've seen frequently over the past few years. This is the Maryland Health Benefit Exchange, state-based Young Adult Health Insurance Subsidy Pilot Program, and we're here today to remove the sunset. This bill came out of a report that was commissioned in 2018 to look at uninsured Marylanders and to see what was the highest population of people who were uninsured and what could we do to entice people to take advantage of the Maryland Health Benefit Exchanges. In 2020, the committee had a briefing on the findings of that report, which identified that young Marylanders age 18 to 34 were the highest population of the uninsured, and most of them were employed, but they were making too much money to get a subsidy and not enough money to afford health care. So in 2021, we passed the first iteration of the Young Marylanders Health Care Subsidy Bill that we put in a pilot for 2 years. At the end of 2 years, we felt pretty good about the results we were getting, but we felt it would probably be a better idea if we got a little bit more data. So we requested a 2-year extension on the sunset. Then the sunset was extended until 2025. Now we're here today. We have all the data we need, and I'm just going to let Michelle Eberly and the others from the Maryland Health Benefit Exchange tell the story, because it really is a remarkable story. This bill has done everything that we designed it to do, and I want Michelle and the rest of the witnesses to really take credit for the incredible work they've done enacting this legislation. So I will now turn it over to them.
Delegate Kerr, and that was your baby, so thank you also.
And good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and committee members. And thank you, Delegate Kerr, for opening this hearing up. For the record, I am Michelle Eberly, Executive Director for Maryland Health Benefit Exchange, and I'm here to speak to House Bill 297 to ask that the pilot program status be sunset and that this program continue indefinitely as long as there is funding through the reinsurance program to fund it, which is an important point. It doesn't take any new funding, no general funds, it's with existing funding. The most important thing of this program is that it has just been hugely successful, and the program speaks for itself. Nearly 65,000 young Marylanders aged 18 to 37 are currently covered. The average savings per month is $38, or 30% of what their premium otherwise would be. Year-over-year enrollment this year for this population is up 21%, and that's compared to our overall enrollment year-over-year, which is 16%. So this age group has really excelled. What we have seen is that now the young adult enrollments account for 36% of our total population of enrollees of over 247,000. And that's really helpful when we look at the morbidity of a risk pool, which the individual market is a risk pool. And we estimate that this volume of young adults has put downward pressure, as we say, on premiums of a negative 1.2% because of that influx of young enrollments. When we talk about equity and looking at how we're covering all of our communities, enrollment in our Black communities is up 29% in this age group. What's most just terrific, we love seeing this, and our Hispanic age group of this population is up 49%. So
you could take, it's worth it. You could take.
And I can wrap it right up. So one other thing I just want you to know is approximately half of the cost of the young adult subsidy program is offset by an increase in what we get through the federal reinsurance funding. So this program almost pays for itself, and the dividends have been just phenomenal. So with that, we request your favorable report.
Let's go ahead.
I'm going to go. My name is Jana Varwig, and I'm here to advocate for the continuation of the young adult subsidy for health insurance. Most of us know a young adult who has been working for a small nonprofit or a small business, or perhaps doing gig work to support themselves. And before the state enacted this subsidy program, these young adults who were working for small employers did not have access to affordable health insurance. My son is a case in point. Like many young adults, he is working for a small employer in the food industry who does not offer health insurance. And so, prior to the young adult subsidy program, he found a health insurance program or policy on the Maryland Exchange. It provided some basic services, but it had a huge deductible. It was $6,000. And so for him, if he were to get sick or be hospitalized, injured, whatever, he would have to pay $6,000 worth of medical debt. That was unaffordable to him, and it would be to many young people. What this meant in practical terms was for that very first year, he did not go to the doctor, he didn't seek medical care at all because he was too afraid of what he would get involved in financially. When the young adult subsidy program was enacted, he went back in, found a policy that he could afford that was had a much smaller deductible of about $2,000, and I think it's gone down even since then, which was much more comfortable for him. And suddenly, this young man who, gets sick like everybody else, started going to the doctor. He started using medical services. And this, I have to say, as a parent, relieved me greatly. As a retired dean of students for higher ed, and I'll wrap it right up, I know that young adults get sick. They can. And this is a very important program for both myself and my family.
Hello, Madam Chair. My name is Sarah Burr, and I thank you and the committee for hearing my testimony in favor of continuing the young adult subsidy. And thank you especially to Delegate Kerr for sponsoring this. I also am a parent of a young adult, and I think all of you who are parents know you never stop being a parent, you never stop worrying. So when my son 3 years ago aged off of health insurance, I was like, oh no, what are we gonna do? together we went on to the Maryland Health Exchange website, which is amazing, by the way, and we were able to find affordable health care insurance, and he was able to keep his same doctor, which was just such a blessing. I later learned through Vinnie DeMarco that this was due to the young adult health subsidy. And now, 3 years later, my son continues to work also in the food service industry. So many of our young adults are working for employers that don't provide health insurance. And so this young adult health subsidy is a real bridge for those folks that don't get health insurance through their employer. So now my son, the rates have gone up as his income has gone up, but he continues to have excellent health insurance that he can afford. So please give HB 297 as amended a favorable report and support making the young adult health insurance subsidy permanent. Thank you.
Questions now. Delegate Morgan. My pleasure.
I just had a real quick two-part question. When you said this program is set up for young adults, the age out is actually pretty high on this, right? It's like in the 30s or something. And then my second question is, I wanted to talk about, we mentioned that the subsidies coming from the match, and that's from the 1% that we're assessing to private health care for the reinsurance. Is there any federal match at all for just the young, for this subsection of that?
So I'm happy to answer both those questions, Delegate Morgan. First of all, let me address the second one. So from the 1%, that is entirely the assessment on the carriers. So it's not any federal funding for this program. And the first part of your question, when we wrote the original bill, we put it for 18, from 18 to age 40. And after a couple years, we saw that we were not spending what we had allocated for the program. So we had originally had it from 18 to 34, and we thought, well, we can increase that to 37, which we have done for 2 years. After the Medicaid unwind ended, and we saw a lot more folks come over that needed health insurance, we now see those numbers really high. So we may have to scale that age group back again to stay within our parameters. But it is 100% the assessment on the carriers.
Okay. Well, I mean, the carriers would tell you that they're passing that assessment on to their customers.
Oh, absolutely. And again, it's very complicated, obviously, because they pass it on to the consumer. How the carriers get that returned is we have that through our reinsurance fund. So we are covering 80% of those claims that are very high cost claims to bring down premiums for everyone. Also, since the creation of the exchange, people know Maryland Health Connection. They know to come to us to get their health coverage. So there's an awful lot of new consumers that the carriers have that they're receiving monthly payments from that they didn't have before. As I said, our enrollment's up to almost 250,000. So I think that is being passed off to the consumer, but it comes back triple-fold in terms of what the consumer receives as well as what the carrier receives.
I appreciate your answer. Thank you, Madam Chair.
Thank you. Thank you, Madam Chair. Explain that 1% tax to me.
Absolutely. And this was a 1% assessment that we placed on the carriers for the reinsurance program, not just for the young adult subsidy. It's for the reinsurance program. And we had to do that in order to have our 1332 waiver, which...
Yeah, not that part, sorry. What are you taxing? What, like you said on the carrier, so
Sure.
What number are you taxing on the carrier? Where do you get that number? 1% of 40 million,
I would have to...
It's the total policies they insure, it's this, I understand the mechanics,
Okay.
but I don't understand which portion of the carrier's balance sheet you're taxing.
It's spelled out in the legislation, and I don't recall it offhand. Every single carrier, we narrowed the carriers who had to participate in that assessment. So I know we took out things like life insurance. They don't participate in that. But I'd have to pull up what the actual legislation that we passed said of who was assessed that. 1%, but we could certainly get
Not
you.
just who, but what portion of their book of business are you taxing?
It's based, I believe it's based on their gross income or the gross premiums, but again, I'd have to look at that. I don't know it well enough to tell you offhand. But
You can give that information to us
Absolutely.
offline and send it to the whole committee.
Yep.
And then one final question, Madam Chair. So it looks like this program is going to start to need general funds, according to the fiscal note? No?
No, there's no general funds with this program.
Beginning in fiscal 2029, a combination of special and general funds is assumed. Reading that out of the fiscal note.
If it's in there, it's not accurate.
Okay. And then the 9 million that you had not spent, is there never an idea to turn that back over to the people that got taxed to lower premiums for people who are paying the tax?
So it's, I mean, it could be 10 cents a person. I mean, we're not, again, we'd have to tell you that specific, but how it works in the reinsurance fund is that we took out for this program, we allocated $20 million per year for the 2 pilots. And when we came back with a change in legislation last year, what had happened was we did not spend that $20 million for the first 2 years, but then we saw in year 3 that we spent over $20 million, so we asked to take the money that we had not spent and roll it over. So now we're rolling over funds that, from that $20 million per year, we're rolling over to allow us to expand that age, as I was talking about, to 37. Any funds that are not spent stay in that reinsurance pool, because this is part of the reinsurance fund that supports the entire reinsurance program.
Thank you.
Thank you, Madam Chair. I think I might be able to figure this out by going backwards. What is the total money collected based on that 1%?
I believe it's about $150 million a year.
So it's $150 million a year.
That is correct.
Okay.
And again, that changes based on number of insured, premiums, what carriers have paid. So there's a lot of variations in that. But when we look at an actuarial assessment of what comes in, that's a number we've been using.
In FY24?
I could get you the exact number, but that's just the ballpark number. When we talk about it, that's a ballpark number. But if you'd like an exact number, we can certainly get you the exact number.
That would be great. Thank you. Thank you, ma'am.
Right, to see, okay. Delegate Vice Chair Collison.
Thank you, Madam Chair. And thank you, Delegate Kerr and Michelle, for being here today and for the bill. So I just wanted to be clear about how the consumer actually benefits from this, because I think that was the question that Delegate Shalega was asking. You know, if that 1% is passed along to me as the consumer, how do I benefit from this program? Let me do some presupposition, and you tell me if I'm right or wrong. I think we heard you say at one point that Maryland has the lowest premiums, gold plans and bronze plans in the country?
That is correct.
Okay. And we keep those rates low because of the reinsurance program. That reinsurance program has allowed us to keep our rates rising at a much slower rate than the rest of the country. Am I right about that?
That is correct.
So if my premium is, and I'm going to go try not to be too wild here, 5 to 10% lower than the rest of the country, I'm getting more than that. I'm getting much more back than that 1% I paid. Is that correct?
That is correct. And may I add one other item, which is very important, which you heard in testimony today, about the deductibles and the cost once you get that health coverage. With those plans, because we have the lowest gold, And our silver plans, our variations make them better than a gold plan. 72% of the people getting health coverage through Maryland Health Connection have a very strong, rich, we call it a rich benefit package with a low deductible. So that's amazing that, we talked about the high deductible plans and the concern of not being able to afford that. 72% of Marylanders are in either a gold or a cost share reduction silver plan, which is even better than a gold.
Okay, great. Thank you very much for clarifying that.
Any other questions? I don't see any, but I do have some follow-up. Because it was my bill and I introduced it, and you know the history well, why did we need this bill?
Why do we need this bill?
Why did we do it initially? What was the state of affairs?
Well, rates had gone up. We introduced the reinsurance bill. We did this. The other thing was, and I can't remember, you'll probably remember better than I, but there was at one point where we were considering imposing a mandate, an individual mandate, and we looked at other options, and I can't remember if this was one of them.
So when I said this is my bill, not this one, but the reinsurance bill.
Reinsurance bill, yes.
And it was because we were in a crisis.
We were.
Right? And there were people that were in the individual insurance market that were paying more than their mortgage and could not afford it, right? And they came and they wrote to the legislators asking for help, right? So what happens when we have, and at that point, right, there were a lot of people that were uninsured. What happens when we have people that do not have insurance? Where do they get their care?
Well, many of them go without care. Many of them go to the emergency room because they wait until it's emergency, and then that cost gets passed on to all of us because it's uncompensated care.
As well. Thank you. Leave it right there. Seeing no other questions, let's go to the person who is here virtually. Stephanie Clapper from the Maryland Healthcare for All Coalition. And thank you for being patient as we ask the questions. Good afternoon, Stephanie. You have to unmute yourself.
Good afternoon,
Thank you.
Madam Chair and members of the committee. Thank you so much for this opportunity to testify in favor of continuing this very successful young adult health insurance subsidies program contingent on sufficient funds available for Maryland's insurer assessment. I'm Stephanie Clapper, Deputy Director at the Maryland Healthcare for All Coalition, here on behalf of over 400 faith, business, labor, community, and healthcare organizations across the state. And you can see some of those 400 organizations on the logo flyer in my written testimony. I really wish I wasn't sick today so that I could be there in person to just really thank you all so much for creating this program, because it has been such a wonderful success to see. Young adults are the age group most likely to be uninsured, and half of young adults who are uninsured report having problems paying their medical bills. But thanks to this program, more young adults are getting coverage. We are improving equity by age, race, and ethnicity. Young adults are better able to afford their premiums each month, so they stay in their coverage throughout the year, and they're better able to afford coverage that has lower deductibles, lower co-insurance, and lower co-payments. It is making a tangible difference in the lives of young adults, and at the same time is stabilizing the risk pool to help all age groups to have lower premiums and to prevent uncompensated care from people having to go to the emergency room when they don't have health coverage. So just truly thank you. This is a wonderful program, and I urge you to please continue it. Thank you.
Advocacy, we really appreciate it. Any questions? Seeing none, thank you for being with us. Have a great day, okay? This actually concludes the bill hearing on House Bill 297, and we're doing well for the committee. Now we're on to House Bill 256. We have 10 witnesses, and that is a departmental bill, Health Occupations Board membership alterations and sunset extension. If you're here for that bill, all of you, please come up and take a seat. And as soon as you sit, will you be so kind and start the testimony? Thank you. And you can pull up a chair or two. Go ahead. Feel free. Okay. Thank you. Who would like to get started?
I'll start.
Thank you.
Good afternoon, Chair Pena-Melnick, Vice Chair Collison, and committee members. I'm Sarah Case-Heron, the Director of Governmental Affairs for the Maryland Department of Health. HB 256, as mentioned, is an omnibus departmental bill for the Department of Health. It includes sunset extensions for 4 of our health occupations boards, and also increases the membership for the board of directors for massage therapists. I'll provide a brief overview and then let our independent health occupations board speak for themselves on each of these extensions. The first piece that this does is for the Board of Professional Counselors. It extends the termination provisions, the sunset relating to their authority for 5 years until 2031. For the Board of Audiologists, hearing aid dispensers, speech language pathologists, and music therapists, it also extends the termination provisions related to their authority for 5 years. For the Board of Pharmacy, it similarly extends the sunset for 5 years until July 1st, 2030. And then for the Board of Massage Therapists, there's both a sunset extension till 2031, and then for their board membership, it increases the board of directors by 1 licensed massage therapist and 1 consumer member for a total of 9 members to represent the number of the actively licensed massage therapists, and intends to lead to more informed and effective decision-making, but I will let our board speak to the goal of those changes. As mentioned, this is an extension bill. The 5 years were chosen to be consistent with our prior extensions for health occupations boards last session, and we do request a favorable vote on this bill today. Thank you.
Thank you. Chair Pena-Melnick and members of the committee, good afternoon, and thank you for the opportunity to testify in support of House Bill 256. I'm Sharon Oliver, the Executive Director for the Massage Therapy Board. In 2016, the General Assembly established the board, and this is our first sunset. Since its inception, the board has accomplished numerous goals and objectives to improve the quality of massage therapy services and to protect the public health safety for the citizens of Maryland. Through collaborative efforts with various state and national stakeholders, Maryland has elevated the educational standards and required training for massage professionals, increase access to massage care by increasing the number of licensed massage therapists available to work in healthcare setting, and improve public safety with the enactment of key legislation in 2022, 23, and 24. We are the first massage board in the nation to enact a law making it a felony to aid and abet the unlicensed practice of massage therapy, providing law enforcement with a much-needed tool to combat illegal activities in massage businesses. Since the enactment of this law in 2024, 2 counties have reported that they've each charged 3 cases under this law. The board continues to improve internal operational efficiencies to ensure the timely processing of licensure application and to increase the workforce. We now accept online application and payments and transition to the from an in-person examination to online, reducing application processing time by 20 days. The board has no outstanding legislative audit deficiencies and respectfully request a favorable vote on House Bill 256. Thank you.
You need to go next. Good afternoon, Madam Chair and members of the committee. My name is Sabrina Lopez, and I am the Vice Chair of the State Board of Massage Therapy Examiners. Over the last 10 years, the board has experienced an increase in workload for our committees, specifically the disciplinary and legislative committees. It has become necessary to increase the number of board members to ensure ethnic and geographical representation and operational efficiency and effectiveness. The disciplinary committee works tirelessly to ensure the protection of the public through timely processing of complaints received. In the fiscal year 2023, 31 cases were adjudicated, 47 in fiscal year 2024, and to date in fiscal year 2025, 29 cases. We anticipate in excess of 50 complaints for 2025. The increase in board members will allow for a more even distribution of the workload and diverse perspectives to make decisions. The board is sensitive to the impact of cultural differences in the practice of massage professionals, and to that end would welcome diversity of thoughts from representative practitioners during its deliberative processes when adjudicating cases. It is important to continue to evolve our regulatory oversight as the industry grows and changes. Expanding the board provides stability and continuity for the industry, allowing practitioners to operate within a clear regulatory framework. A larger board can engage in long-term planning and policy development, ensuring the industry adapts to changing circumstances and remains well-regulated. Ensuring a quorum is essential for the board to function effectively. A larger board can maintain a quorum even during periods of vacancy, ensuring continuous and effective governance. Continued oversight helps maintain high standards in the massage therapy industry, protecting both practitioners and clients from unqualified or unethical practices. The board can better manage the increasing workload, enhance its effectiveness, and continue to uphold the standards of massage therapy industry. This approach not only addresses current challenges, but also positions the board for future success. The board respectfully requests a favorable report on House Bill 256.
Thank you. I'm Elizabeth Guroff. I'm a licensed clinical marriage and family therapist and sit on the licensing board for professional counselors and therapists. We're also requesting a favorable vote on the bill. The Board of Professional Counselors and Therapists is vital to the ethical and safe provision of behavioral health services for our professionals that we oversee at the board. And although we have had our challenges over the past few years, I'm happy to discuss those and request a favorable vote to allow us to continue to protect the public and address all of the challenges.
Good afternoon again. Keena Stevenson, Executive Director, Board of Audiologists. The board is in full support of House Bill 256 to extend our sunset legislation. We're requesting 5 years to be in line with our sister health occupational boards. The board currently services over 6,200 licensees with an average of 30 new licensees on a monthly basis. The board also has a substantial economic impact, bringing in around $200,000 in application services and as well as licensing services. Our board provides a service of not just licensing, but disciplining and also providing full operational and technical support to our licensees and constituents. The board does respectfully request a favorable report on HB 256.
Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to testify and answer questions that we may have. I do have a question. Can you tell me when the board will fully implement House Bill 628 from last year? A quick recap was the bill streamlined licensure for marriage and family therapists without state license in good standing. The effective date was October 1st of last year. Yet the application for out-of-state applicants on the website hasn't been updated.
Say one more. So the bill for out-of-state?
Correct.
And you're saying the application has not been updated on the?
Correct.
I know that with our credentialing committee, we've been working, there's been quite a bit of legislation or changes in our regs that have not been updated on all of our applications. So I know that our credentialing committee has been working on getting those current. And we were trying to put them all up at the same time so we can get back to you on a
Okay,
date.
because that was due October of last year.
I can definitely look into it and let you know.
All right, thank you.
Yeah.
Thank you, Madam Chair.
You're welcome. Any other questions? Seeing none, thank you so much for your testimony today. We do have a couple of people. We have NCCA, favorable with amendment, and we have a virtual person. Will you bring them up as well, please? And you can get started. Good afternoon. How are you, Ann?
I'm well. Thank you, Madam Chair.
That's good.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Ann Seacott. I'm actually testifying this afternoon on behalf of two clients, the Maryland Association for the Treatment of Opioid Dependence and the Maryland Addiction Directors Council. We are supportive of the legislation, asking for one amendment, which is a shorter sunset for the Board of Professional Counselors and Therapists. For a number of years, there have been problems with the process of getting applicants' decisions made related to certification and licensure approvals, as well as trainees. It is very common at meetings I attend of the associations for people to talk about the 6, 7, 8, 9 months that it takes to get folks through the process, how difficult it is to get a response from the board when they make phone calls to staff. We know that they are very understaffed. We know that there are times that board members actually step in and do some of the work of help the staff because they are so understaffed. They have had 6 executive directors in the last 7 years. So, you know, this is a significant problem that exists in this board, and we appreciate all the work that they are doing. We appreciate the fact that we understand there's somebody new coming on board next week. We really do hope that that person is able to bring better organization and hire the people that need to get hired to make the work much more effective. We have a workforce shortage in behavioral health. There are legal requirements that some of these programs have about staff to client ratios. So it's really imperative that this part of the process work efficiently. So that's why we're asking for a shorter sunset and we'll be requesting a more formal review so that we're able to get a good handle on where the fixes need to be made to the process.
I'm going to open it up for questions. Any questions? Seeing none, thank you, Ann. We appreciate it.
Thank you very much.
You're welcome. May we please go to the virtual one? Thank you.
Good afternoon.
Good afternoon. How are you?
Committee Chair and members of the committee, I'm Dina Spates-Napata, Executive Director of the Maryland Board of Pharmacy. The evaluation conducted by the Department of Legislative Services in October 31st, 2011 recommended the Board of Pharmacy sunset date be extended to July 1st, 2023. Subsequently, an emergency bill was introduced during the 2023 session to further extend the sunset date. Therefore, in accordance with HB 256, the board agrees with the sunset recommendation, and we urge a favorable vote on HB 256. Thank you.
Wow, great timing. Thank you. Are there any questions for this witness? Seeing none, thank you so much for being with us and for making the time. We really appreciate it, okay? Thank you, ma'am. Have a great afternoon. Okay. This actually concludes the bill hearing on House Bill 256. Next, we're going to House Bill 382, and that is Delegate Johnson, Maryland Medical Assistance Program and Health Insurance, Step Therapy, Fail First Protocol and Prior Authorization, Prescription to treat serious mental illness. 11 witnesses. We're doing well. And you can bring your panel. And feel free to pull some chairs, all of you, just come together.
That title is a mouthful, Madam Chair. I didn't
It
come up with
was,
that.
but it gave you time to get it together there.
All right. Good afternoon, Madam Chair, Vice Chair, and members of the HGO Committee. I'm Delegate Steve Johnson, here to present House Bill 382. I hate even repeating this title, but Maryland Medical Assistance Program and Health Insurance, Step Therapy, Fail First Protocols, and Prior Authorizations, Prescription Drugs to Treat Serious Mental Illness. This bill's pretty simple. If you have a serious mental illness, you should not have to fail on a medication first. And when we say serious mental illness, that's exactly what we mean. This bill would pertain to schizophrenic spectrum disorder, PTSD, major depression, bipolar disorder, and medication-induced movement disorder associated with the treatment of serious mental illness. Fail first, otherwise known as step therapy, in the insurance protocol that requires to try one or more medications recommended by the insurance company prior to having access to the drug originally recommended by your provider. For example, if a provider prescribes drug A and their insurance requires them to try drug B, which usually is a lesser costly drug, the patient must show how the medication failed them first before drug A is covered. While I do understand the insurance steering patients to the cheaper, appropriate drug, fail first often results in delaying patients' access to needed care. Panelists will emphasize why this is a huge detriment for the community experiencing serious mental illnesses. This bill will also apply to Medicaid. Though we disagree with the physical note state physical impact, we have in compromise included language that says that should the department experience an increase in costs of more than $2 million to Medicaid in any fiscal year, then that section of the bill is no longer in effect. I do also want to point out that buried in the physical note, the department states expenditures may be offset by savings from reduced delays in treatment and reduced medical costs such as provider visits and hospitalizations. And we've seen this a lot when we see physical notes, that they don't often take into account the savings and add that into the formula when they come up with these physical notes. So we really don't know sometimes if it's a cost to the state or it's actually a savings to the state. So I'm glad that they have at least added that language in this physical note. The department may also say that what they do is not step therapy or fail first. We respectfully disagree. Medicaid patients are obligated to use a drug on their preferred list. We know this to be step therapy. Here is what other states have said. New Jersey, as they are working through a similar ban on fail first protocols, has found an indeterminate physical note stating that there is actually potential for annual cost savings due to better health outcomes leading to reduced future treatment costs. In Michigan, Michigan Department of Health and Human Services Psychotropic Best Practice Work Group reports access to care issues for a person with mental illness can be more difficult than medical illnesses. Thus, it is critical that barriers to care be as few as possible for individuals seeking treatment for their mental illness and for the providers willing to treat them. It is also important to note that data shows vast majority of psychotropic prescriptions in Michigan Medicaid are for generic drugs. 85 to 87% in fiscal year 2017. Michigan's psychotropic care carve-out in Michigan since 2004 has not resulted in prescriptions flooding Medicaid with claims for brand name drugs. In Utah compliance, their dispenses written or preferred drug list compliance, Utah created open access by implementing a dispense as written law for the antipsychotic class. That was caveated by a requirement that PDL adherence remain at a certain percentage, 75% of the prescriptions by July 1, 2019, needed to be in compliance with the PDL, the preferred drug list. Compliance with PDL at the completion of the state fiscal year 2019 was actually 91%. A study was done, research on the issue utilization management, use of serious mental illness and antipsychotics. According to the study, patients with schizophrenia subject to formula restrictions were more likely to experience a hospitalization. They had 23% higher inpatient costs and 16% higher total medical costs. Similar results were found with patients with bipolar disorder, with those subject to formulary restrictions being more likely to be hospitalized, 20% higher inpatient costs, and 10% higher total costs. From Columbia Data Analytics, a review of Medicaid, medical, and pharmacy claims by Columbia Data Analytics for patients living with serious mental illness from 2016 to 2022 demonstrates that Medicaid programs offering open access to antipsychotics may realize lower overall costs. Both patients and the state budgets may benefit when Medicaid helps patients access the mental health drugs they need. Now, we definitely agree with that. You'll hear from several advocates why this bill is so important. It is for these reasons we respectfully request a favorable report on House Bill 382. Thank you. Who wants to go next? Go ahead.
Good afternoon, Madam Chair, Madam Vice Chair. Thank you for hearing this bill today. Members of the committee, my name is Michael Gray. I'm Deputy Director of NAMI Maryland. NAMI is the National Alliance on Mental Illness, and NAMI Maryland represents over 58,000 individuals and families within the state who are impacted directly by mental illness. This bill is a big one for us and our members. It's a big one because we hear almost daily about the people we represent struggling with fail-first protocols to access the meds they need when they need them. Oh, is that better? All right, all right. So again, people struggle every day to access the meds they need when they need them for serious mental illness. Now, failing first with the mental health condition is different than in most other medical specialties. Failing first in these cases may mean a return to psychotic state, return of major depression and suicidal ideation, return of frequent and severe panic attacks. It's just different in mental health. But I want to focus on one thing that Delegate Johnson said in his testimony, and that's this part from the fiscal note, right here. In the fiscal note, expenditures may be offset by savings from reduced delays in treatment and reduced medical cost. We couldn't have said it better ourselves. We don't believe this bill will cost the state any money. It will save money and it will save lives. NAMI would not spend our time and waste your time advocating for a bill in this particular legislative session that would cost millions of dollars for a new initiative. We wouldn't do that. We're so confident in that the advocates for the bill and the sponsors built in a self-terminating clause, as Delegate Johnson pointed out. So again, this bill will save lives and will not cost the state a dime, so we urge a favorable report. Thank you.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland here in support of House Bill 382, speaking on behalf of the Maryland Behavioral Health Coalition as well, which has prioritized this bill in 2025. And I was just here last week on a bill talking about the access to care crisis that we have because of the workforce shortage in Maryland's behavioral health space. And despite that, we allow insurance companies to undermine the clinicians that we do have by allowing them to just veto treatment decisions and substitute their own. We make it so hard for people to get the care they need when they need it. There are workforce challenges, network adequacy challenges, stigma to contend with. And then on top of all that, we allow insurance companies to throw up these barriers to care that can lead to a worsening of illness and an escalation of symptoms. And then we wonder why people with mental health issues are disproportionately accessing care in hospital emergency departments. These are cost containment practices. Make no no question, these are cost containment practices, but while the practices may reduce costs for insurers, the costs don't just disappear. They are borne by the taxpayer in the form of more expensive and preventable ED visits and homelessness and criminal justice involvement. And, it's just a really egregious situation. We require people to purchase health care coverage, and then we allow these practices to prevent them from getting the health care that they're actually paying for. And so I urge you to put an end to these unfair practices and vote favorably on House Bill 382. Thank you.
Thank you, Dan, for working with the committee on AOT. You were instrumental in helping us get that through. So, the committee is giving you your flowers. Thank you.
Thank you, Madam Chair.
Right.
Thank you all for working with me.
Next.
Thank you so much for the opportunity to speak today. I'm Michelle Lifshin, representing Honor Own of Maryland, in support of HB 382. In addition to our written testimony, I want to share my own personal experience. The decision to take psychiatric medication is a highly personal choice. All medications incur risks of adverse side effects and reactions that can vary greatly from person to person. It took me 6 years of cycling through multiple mental health medications to ultimately find one that was effective without causing severe side effects that impaired my ability to function on a daily basis. In my early 20s, I was prescribed a series of generic medications, typically approved by insurance. The first one gave me side effects so unfamiliar, sudden, and severe that I had to take a leave of absence from school, and ultimately I entered into intensive treatment. I then tried other medications with side effects that were less severe, but still substantially impacted my ability to function. After a few years, my psychiatrist finally suggested that I try a newer medication, warning me it was not typically approved by insurance. The prior authorization process delayed my treatment for over a month. It took weeks to be reviewed and denied by my insurance, and then for my overburdened psychiatrist to contest and resubmit, only to be denied a second time. It was actually my pharmacist who advocated with the insurance company on my behalf, which allowed me to receive approval for the medication that ultimately has been the first to work effectively for me with little side effects. Since then, I've been able to finish my master's degree, work full-time, and enjoy a full life. My story is just one of many. Decisions about medication should always be led by the individual consumer in consultation with the healthcare provider team. This bill could improve care by prioritizing consumer choice, protecting patient-doctor decision-making, and promptly timing access to desired treatment. We urge a favorable report. Thank you.
Your personal story, okay? We really appreciate it, and I'm so glad you're doing well.
Thank you.
You're welcome. Next, please.
Good afternoon, Chair Penemelnik, Vice Chair Cullison, members of the committee. My name is Dana Kaufman on behalf of MedChi and other healthcare practitioner organizations. This committee first discussed step therapy in 2013 when legislation was introduced that would have created a broad override policy based on the practitioner's professional judgment. The carriers and the PBMs opposed that bill, and it did not pass. So back in 2014, and I said this yesterday, this was the first piece of legislation I worked on for MedChi. Legislation was reintroduced, and that narrowed that initial legislation and basically said that if you had been on a drug for 365 days, then you could override the step therapy policies and stay on that drug. Again, the carriers and the PBMs opposed it. Luckily, this committee passed that legislation, and actually they passed it by reducing that time frame from 365 to 180 days, giving more protections to patients. I'm giving you this history lesson for one reason. Even though the carriers opposed it, you passed it, and that law, I think, has been a success for 10 years. And the concerns that were raised, the safety concerns, the cost concerns, and other reasons have never materialized. The bill has been a success. And in fact, I am unaware of a situation where you have passed legislation that has been opposed and had to come back and change it because of a concern that actually materialized. So here we are now in 2025. And we have legislation, again, that was introduced in 2023 that was broad and now has been narrowed down to really look at those just very few conditions. Lastly, I just want to point out a couple things for some facts. Between 2020 and 2023, we've seen an increase of 46.7% in denials by carriers. Of that, 72.2% have been in pharmaceuticals. So we are continuing to see denials, and that is one of the reasons for the urgency in this bill. Thank you very much.
I'm going to open it up for questions. And then after this panel, because we have more people, I'm going to call an unfavorable panel just to be balanced, okay? So are there any questions for this panel? I see first Delegate Kerr, followed by Taveras, and then Bagnall.
Thank you, Madam Chair.
My pleasure.
Michael, we work a lot here in this committee with in the mental health area and with mental health medications, and we understand that it's really hard to find a medication that works. Sometimes they don't work. And then to find one that does work, to do that balance between the effectiveness of the medication, balancing against some of the side effects. So, and we've learned that maybe sometimes that you have to change medications even weekly. So if you've got a step therapy where a patient has to fail, to what extent does that complicate treating your patient and finding that right medication at that right dose?
Sure. So thank you for the question, Delegate Kerr. I'll say I'm not a healthcare provider, but speaking for NAMI and our membership, we know that when you have a disruption in the course of treatment, after a long agonizing process of provider working with the patient to get the medication they believe will work best, having that medication for, like you said, a week or even years, and then all of a sudden having to start over. Maybe you change insurance providers, whatever the reason. Having to start over is, as I said in my testimony, is not just disruptive, it can be life-threatening. It can certainly be life-altering. And having to start that process all over again, it leads to, as Dan said, it can lead to hospitalizations, incarceration, being unhoused, chronically unhoused. And we see that across the state every single day with Marylanders living with serious mental illness. Excuse me. So, yeah, it's a major problem.
Thank you. Thank you, Madam Chair.
You're welcome. Delegate Taveras.
Thank you, Madam Chair. This bill is very personal. But with that said, are you aware of patients or caregivers who have had medical expenses personally due to not being able to access the medications they need in a timely manner? And I'll direct that to anyone who may have.
One person.
Personal experience.
Michelle, do you have personal experience you want to share?
So I lost the money all the tuition money from school for that whole semester. I left school and then I entered into intensive treatment. I was seeing a therapist on a regular basis and a psychiatrist, but the decision to prescribe me generic medication was made because they knew it was going to be prescribed. They knew it was going to be covered by my insurance. And then the second time, another generic medication was prescribed despite issues with the first generic medication. So, yeah, I mean, there were costs incurred from the loss of schooling despite engaging actively in treatment at the time.
Thank you.
If I can just add also, I mean, my experience, that's just my experience, but for folks also dealing with serious mental health issues, it can also mean it can mean that their needs are not getting met and that they can further then be entered into the hospital, and that is additional huge expenses. So I just want to add that. That's not my personal experience, though.
You're welcome. And I wrote Bagnall and then Hill.
Thank you, Madam Chair, and thank you to all of you for bringing this legislation forward. I just want to drill down a little bit because I know that one of the therapies we're talking about is injectables, and I just want to ask, when you have something that is like a once a month maintenance, or once every 3 weeks or once every 6 weeks. How effective is that in terms of the maintenance of severe and persistent mental illness, when you can have that continuity and you don't have to have like a daily accounting? Anyone who could answer that?
Whoever wants to answer. So thank you for the question, Delegate Bagnall. The answer is that is, studies have shown that the long-acting injectables are very effective for treating, for example, treatment-resistant schizophrenia, just one example. And that, again, this would apply in that it takes patients and sometimes family caregivers so long to advocate to get the exact drug they want. But those LAIs that you mentioned, there's only so many of those on the market right now. In the history of the treatment of mental illness, that's a relatively new method of treatment. So it's very important people can get access to that in a timely manner when they need it, and continue that access if it's working for them going forward forever, and not have any disruption in access. So yes, they can be more effective in some cases, but it's very important people have access to those and maintain access to those once they have it.
Thank you. And if I could have a follow-up. And I don't need a dollar amount, but as we are talking about the cost savings that isn't identified in the fiscal note, can you speak to the cost of going through the criminal justice system when you actually have a gap in your care and you do have a crisis situation? Sure.
So anytime you have justice involvement because of mental health symptoms, that is often something that someone has not planned for. Some people have legal expenses that they know are coming, right? But not in the case of being denied a medication, and then your symptoms return or you decompensate, and then you're charged with a crime because of activities. There's a obvious example of someone who is accused of a very serious felony and has all the expenses incurred and their life-altering consequences of incarceration, the cost of legal fees and everything else. But something as lower dollar amount, but very much life-altering, someone, say, who is doing well on medication, they lose access to medication, they decompensate, they have co-occurring substance use disorder, and they're charged with driving under the influence. Well, that's, for someone who is, let's say, Medicaid eligible, the few $1,000s that they'll incur in that process could be financially devastating. So that's just one. There's two ends of the spectrum there, but most of them fall in between. So great question, but it happens at every step of the process. There are expenses, but also the toll it takes on a person and their family.
And potentially it could have been avoided if their maintenance of care had been sustained. Thank you.
That's right. And then there's also a cost to the state that's incurred there all along the way, right?
Delegate Hill.
Thank you, Madam Chair.
You're welcome.
Ms. Kaufman, as you said, you've been working on this for, I guess, since you were in grade school.
I wish.
And so, and a lot of that was negotiating on different bills, providers, insurers, patients. When a step therapy works well, do you have any idea how often that occurs, or how much money is saved, or how we get to good outcomes? Can you address what happens when step therapy works well? Do you have any sense of that?
I think that there's two different types of step therapy too, or two different ways to look at it. There is the newly diagnosed individual who has never been on medication. So when the insurance company says, I would like you to try these 4 drugs before you tried this drug, I think that is a different scenario than somebody who has been well maintained on a drug. And we do have, again, our step therapy law now does have the 180 days. However, what it doesn't cover now is that newly diagnosed individual when there is an issue that for some reason they might not be able to take a certain drug that is the preferred drug. Now, I will acknowledge that we have an exemption process in step therapy. That's what passed in 2023 when this provision was taken out. But one of the issues with the exemption process is, one, the discretion is still within the carrier to decide, and it can still be a delay. So it's still going over the prescriber's, clinical judgment. So I think that that's probably one of what I have seen mostly when I've been looking at this for 10 years. It's the issue of really when there is the prescriber has a different clinical judgment than that of the insurer. And I don't think, especially when you're looking at these types of conditions, these are the most serious mental illness. And these are the conditions that end up in our emergency department and that board in our emergency department that are the most hard to control and really have that adherence to a treatment plan.
Thank you. May I have a follow-up?
Yes.
Thank you. So in your experience dealing with the providers, the patients, the families, the insurers, pharmacists, when that clinical judgment is over, so the person, the provider who's seeing the patient has a relationship with the patient, knows all the extenuating circumstances beyond the 4 or 5 things that go into the online form, when their decision is overridden, do the insurers bear any cost or responsibility with respect to middle of the night phone calls, with respect to unnecessary emergency room visits, with respect to do they bear legal responsibility if things go really sour? Are they in court having to defend themselves for what they did? Do they have any liability when they're making these overriding decisions in place of the person who is actually engaged with the patient?
No.
Oh, okay, thank you. Thank you, Madam Chair.
I don't see any other questions, and I'm going to ask a few that I did not hear. You might have, oh, all right, Alston. Did you just put the light on? Oh, you did. I have to tell you, I'm going to start penalizing you for doing that. Go ahead.
Thank you, Madam Chair. Appreciate the opportunity. So my question is, the fiscal impact statement in the letter from the Maryland Department of Health implied that there's a significant cost to the legislation. I was wondering if you agree with that, if you would be so kind as to answer. As for Ms. Kaufman.
Oh, sure. I think it's very difficult to take a look at the fiscal notes, just because, again, we don't have the offset of cost savings that can occur. And I think we've made the point that if an individual is taken off or has a delay, then it is going to end up costing the system more. And not just the medical system, but the societal system. So it's very difficult to take a look at. And I think also we need to remember, too, for our Medicaid recipients, our appeals and grievance provisions do not apply to our Medicaid program. They have their own, which I can't tell you what those are. I think it's definitely not as robust as our appeals and grievance. But I also do know that with the fiscal notes, we saw it last year too on the prior authorization bill, the fiscal notes that are coming in very, very large. And I do think that it would, we would have a better understanding if the fiscal notes would have more data on the cost savings as well.
That was a good question. Actually, very similar to what I'm about to ask. If you look at page 4 of the fiscal note, can you go to the 1, 2, 3, 4, the 4th paragraph? And I'm going to sort of ask it with more specific with the numbers. It says the bill includes a termination provision trigger if DLS determines by April 30th that the bill resulted in cost increase to Medicaid of more than $2 million from the immediately preceding fiscal year. Thus, based on the estimated impact on Medicaid expenditure under this analysis, likely well in excess of $2 million, the bill likely terminates April 30th, 2027, after the initial report is presented. Thus, there is likely no effect beginning in fiscal 2028. What will you say to that?
Thank you for the question, Madam Chair. And we disagree that it will cost more than $2 million. We disagree that there'll be any net increase in cost to the state in any given year. And the reason, well, there's two reasons that we believe that. Number one is data from other states. Delegate Johnson mentioned several other states that have same measures in place, and they either have relatively recent measures and they've seen no cost increases, or they've had this in place for a very long time and they consider it to be a cost savings mechanism. In researching with sponsors and other advocates for this bill, we found Connecticut, for example, they just don't allow step therapy for mental health conditions, and they see it as a cost savings mechanism within their Medicaid system. And that's reason number one, is data from other states. Reason number two is the kind of common sense, the logic of it that we've discussed here and that several delegates had questions about, which is the offsets. As Ms. Kaufman mentioned, the offsets. So you spend a certain amount of money to make sure people get the drugs they need when they need them, but those costs will be offset by savings, by prevention of need of much more expensive treatments for the same patient down the road.
And if you go down to the last paragraph of page 4, it states the Department of Budget and Management, DBM, advises that the state employee and retiree health and welfare benefits program currently has prior authorization or step therapy rules in place for 5 drugs associated with the mental health conditions indicating in the bill. Using current utilization data through November 2024, the estimated annual incremental impact of the bill on the program is between $500,000 and $1 million after rebates. It says, thus, expenditure for the state employee and retiree health and welfare program could increase by as much as $500,000 in fiscal 2026 and by as much as $1 million annually thereafter. It says DBN further advises that the bill could have longer-term cost implications as it will prohibit the state's future ability to expend prior authorization or step therapy. Can you address that, please?
I'll take that question. You know what's interesting when I look at these two fiscal notes is if you look at the Department of Budget and Management, it doesn't have any numbers as far as what assumptions are being used and how many people that is covered. But it's a little ironic that you have a $1 million, up to $1 million. But then if you look at Medicaid, it's like, what, 81 million. I mean, the disparity is huge. But so I think that is one issue that just to me kind of jumps out when they don't say how many individuals would be affected by the Department of Budget and Management's numbers. But I also want to point out too, and when I took a look at the 2013 and 2014 legislation, 2013, the fiscal note for that broader bill, which was much, much broader than this bill, that had no fiscal note. And the reason is because the state employee health benefit plan is an ERISA plan. It is voluntary for the state to cover those costs or that benefit. Now, what they will say is that they do, but that is a discretion on their part. In 2014, the fiscal note, I believe, they said up to $100,000 because they already had a step therapy coverage. They had 130 days, which we moved it to 180 days. So it actually expanded the benefit to state employees. But it also proves the point that the state has the discretion to craft their own plan and not always go by what we pass here. So I think that is just an interesting point that kind of gets lost, that the state has the ability and the discretion to do this, but if it's too expensive for the state, I would not. There's still so many people in the fully insured marketplace outside the state that will benefit from this. So I say we cover who we can, keeping in mind the fiscal note to the state. But again, it's an ERISA plan. It doesn't have to apply. But I just wanted to point out that kind of discrepancy with, you've got $1 million on the state and then you got 80 some million on Medicaid. And how do those two relate to each other as far as how they came to be calculated?
Assuming that you would fix the provision that trigger the termination by the LS, that we fix the date, can that be a way to prove whether those assumptions are correct or not?
It almost serves as a pilot program.
Right, but that's where I'm getting.
Yeah, it serves as a pilot program.
Yeah, so is there a way to draft this in such a manner that let's make it a pilot and see if the sky is going to fall, right? If this is true.
And I think we can definitely work on that with you.
Because otherwise we will be here every single year with the same arguments, the same assumptions, right? And if other states are doing it and they show that, it's working, I would have assumed that some of the same carriers that are here are in those states, correct?
I would assume, but I do not know that, so I don't want to say yes or no. But the carriers can probably answer that question themselves.
So I think that, perhaps, and I'm sorry I did not speak to the sponsor of the bill, but I'm thinking out loud, a pilot, this can be drafted that we'll make it a pilot and see if it works, right?
Yeah, we can do that.
Any other questions from anyone? All right, seeing none, thank you so much for your time and for your patience. And thank you, those of you that are waiting to be called. We are making good time. Let's just go quickly to an unfavorable panel because I want to be balanced. Let's call Matt Chantillano, who is a friend of Delegate Ashanti Martinez, okay? And Kimberly Robinson, who's a friend of Ashanti Martinez. Okay. Good afternoon. And Kimberly.
I can if I can follow it up with 2 minutes.
Ms. Robinson Matt can explain the joke to you later on.
Thank you.
Okay.
Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 382. Thank you all. Good to see you. First time at this table this year. As many of you know, we passed a significant update of the step therapy law during the 22 session that just became effective last year. And then we layered a significant prior authorization policy shift last year. We haven't even had enough time for claims to come in since that law was implemented. It just became live, active 29 days ago. So we have no idea how to analyze the impact of this bill with all the changes we've made in the General Assembly the last couple of years. The prior auth effort from last year had major impact on drug approvals, timelines, appeals and grievance, and standards and criteria, including the adoption of criteria based solely upon behavioral health and substance use disorder treatment guidelines. Also, as I think we heard before, it was mentioned that anyone can request an exemption from a step therapy requirement. As you all might remember, many parts of the discussion last year centered around cost and the inability to move the bill that this committee wanted to move because of the reauthorization in the behavioral health drug space. This bill goes further than a reauthorization and has a blanket prohibition on step therapy and prior authorization. And I think that that results in what you see in the fiscal note. There's been a robust conversation already about the fiscal note, and I'm sure that conversation will continue, and we can be a part of that. But just to lift the prohibition on, or have a prohibition on step therapy and reimbursement will have cost impact. There is no doubt about it, and it will happen in the Medicaid plan. It will happen in the state health plan, and it will certainly happen in the commercial market. And I think that's why you saw that cap from MDH, because they know that they're going to go past that 2 million. That is one of the bigger segments of the market, but we also have other aspects of the healthcare landscape that would be affected by this legislation. So we would say we don't want a one-size-fits-all approach. We would let the bills take the course that have been implemented over the past 29 days and the year before, and we respectfully request an unfavorable report.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee, Kimberly Robinson. For the first time before you, representing Cure First Blue Cross Blue Shield, here respectfully requesting an unfavorable report on the bill. Clearly, I won't repeat what Mr. Celentano said. I will just add to the conversation. One, as you know, we have a concern as the state passes laws that drive up the cost of health care. we know the first piece of access when it comes to health insurance is affordability. If everybody could pay for their health care costs out of pocket, we would never sell a single insurance plan. That's just the reality of how expensive health care is. And so the goal in making health care and health insurance affordable and available is not to keep people from care. It's trying to make sure that the largest amount of people can get as much care as we can possibly make work in a way where people can still be able to afford their premiums. And so when policy drives up premium, people stop buying health insurance, and that becomes a different challenge from us from a healthcare perspective. In this particular case, there's a reason why there are exceptions to step therapy policies. There's a reason why nothing is ever an absolute where there's no way around it or no way to ask for a reconsideration or an opportunity to talk about it. And we think that that is an important thing for us all to remember. A lot of the conversation focused here on Medicaid. We know they have fiscal notes. Commercial doesn't get fiscal notes on bills. So a lot of that is focused on that. There's even an out in the bill, as you talked about, with the $2 million increase. There's no out in the bill for commercial insurance. And there's no out for those ratepayers who, if this does go the way as anticipated, see their premiums go up when they go to pay their premium annually for their health insurance. And so we think that that's why there needs to be more discussion and some consideration about how all of this works together. I can say for us, we see that there's a very small number of very expensive drugs who drive a lot of the costs in this space. It is not every drug that treats a serious mental illness. And the ones that we are engaging with on our step therapy have several therapeutic equivalents. Our goal is not to keep people from care. And I'm happy to answer questions. Thank you, Madam Chair.
And thank you, and welcome to the committee in your new role.
Thank you. I was here with Dana in 2013 wearing a different hat, but yes.
Thank you, and welcome. We're going to open it up for questions. Delegate Morgan, you're welcome.
Thank you, Madam Chairman.
You're welcome.
Matt, I was thinking about this. Has this been tried other places in the nation?
So Delegate Morgan, I operate here. I live in Maryland, and I know the most about Maryland's policies, but I have heard some of the proponents in some of the other states that were suggested, and two of the programs that were suggested were Connecticut and Michigan. Connecticut and Michigan is mostly based on the Medicaid programs there. Michigan and Connecticut operate in a fee-for-service setting. That is not the way Maryland operates. We operate, the economics are just different, right? So we operate in a managed care organization sort of setting where the rates are negotiated. We also have a behavioral health carve-out. So the way that we approach healthcare is fundamentally different than fee-for-service. So some of the states that were suggested, there might have been savings there, but it's not necessarily apples to oranges, right? You could have savings, but it doesn't translate to Maryland. Just because you cut out a slice of a lemon doesn't mean that it translates to the slice of a watermelon, right? And I'd have to see the data to be able to give you sort of impact to where it is in Maryland.
Okay, sounds good. Thanks. Thank you, Madam Chair.
Delegate, my pleasure. Delegate Kaiser.
Thank you, Madam Chair. Mr. Celentano, part of what I heard you say at the beginning of your testimony was part of the reason behind your opposition was all the changes since last year and all the things that have happened in trying to get a handle on things. Did I hear you correctly?
You did, Delegate Kaiser. I mean, one of the things we heard from the proponents was delays, and that is potentially possible in the last couple of years, but the prior authorization bill that we just passed has a lot of attention focused on timelines and condensing those timelines. And I am hopeful that all the work that you all did last year will lead to less consumer dissatisfaction with the ability to have those drugs approved.
Madam Chair, if I could follow up. I guess I was just asking a shorter question. So if part of your reason is that we had all the changes since last year, so it's hard to support it this year, what was your reason for opposing it last year at the same hearing?
We actually were supportive of the prior authorization bill.
Not of this bill?
No, because this is a further step that goes past where we were last year with the prior authorization bill, and we think it's going to have bigger cost impact is one of the reasons why we're opposed to this bill.
Thank you.
Oh, thank you, Madam Chair. And Salentino and Robinson, very brilliant people. And the major Three key points. The bill, this House Bill 382, wants to remove barriers to mental health medication and ensure timely access to treatment and prevent costly treatment delays. And the whole idea is improving patient outcome and mental health stability. That's what this committee believes. Is there middle ground, compromise ground?
Well, Delegate Banderi, we are always willing to sit down and talk, and thank you for calling me brilliant. That's what happens when you're a friend of Delegate Martinez. But I will say that there's been a lot of discussion here on this bill, and the timeframes that have happened, to not go back to Ms. Kaufman's first sort of bite at the apple here at 2013 when we first started to address this. I was like, a toddler at that point, so I wasn't here. But lots of things have changed since 2013, right? In about the early 2010s, the percentage of your premium in the commercial market was roughly 4 to 6% went to prescription drugs. It's now pushing 40, right? Health insurance is really, really expensive. Health insurance is really, really expensive because healthcare has gotten completely out of control expensive. And if we don't do something to address the incredible rise in cost of prescription drugs, I don't know what we're going to do in the future.
Thank you.
Delegate Bagnall.
Thank you, Madam Chair.
I had a senior moment for a minute. Go ahead.
Good. Thank you, Madam Chair, and thank you for being here today. Just to clarify for us, the insurers also cover emergency room visits and hospital stays. Is that correct?
That's correct.
So were you aware there was a recent poll by the National Access, the Patient Access Network that looked at Fail First policies across the country, and they found that 1 in 5 adults who were required to fail first had to have an emergency room visit, about 21%, or were admitted to the hospital, about 20%, as a result of the policy. And do you see that as a cost savings or a cost to the insurers?
I have not seen the study. I don't know how to respond to it. So instead of me opining on something, I'm just not going to, if that's okay. I would love to look at it, and I can talk to you after about it.
I would be happy to talk with you offline. Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you both, and congratulations, Ms. Robinson.
Thank you, Dr. Hill.
Present role. Do either of you have any evidence of improved outcomes with step therapy policies, not finances, improved outcomes? Fewer deaths, fewer hospitalizations, fewer involvement with the criminal justice system, shorter emergency room stays, better, more stabilized family, less required additional time with the therapist and in therapy, better job stabilization. Any evidence, since you've been doing it for a while, I know things take time to change, but do you have any evidence that you can share with this committee that tells us that what we're concerned about, which are outcomes, and we're concerned about finances too, but we're really concerned about clinical outcomes? Can you give us any evidence that this has improved those outcomes?
Thank you for the question, Dr. Hill. I can't say that I have that with me today. I don't know that for some of the things you talked about, any health insurer could have line of sight into everything that's happening outside in someone's life. We don't gather data about your employment. We don't gather data about your criminal record, right? So there's some things we're just naturally not going to have interacted with to answer that question. I did get a question yesterday across the street in the Senate that did ask about how often someone starts on the drug and then does have to escalate to something else, how often a provider may ask for an exception, what's that frequency, how often they granted, and I'm requested that data, and I can at least come back and talk to you about that. But I don't think realistically that sort of more holistic look at outcomes is something that we could talk about.
Thank you, and I would like to see what you give this. And Madam Chair, may I have one follow-up?
Yes.
Would you agree that perhaps the clinician does have that more holistic perspective on whether family situations are improved, there's job stability, fewer ER visits, and all those other things that even though the insurance may not, that maybe the person in one-to-one care with the patient might have some of that information?
I would suspect that that provider who is dealing with that patient on a regular basis is going to have a more holistic sense of what's happened to that patient, yes.
Thank you. I appreciate that. Thank you, Madam Chair.
My pleasure. Any other questions? What do you think about the idea of a pilot that shows, to show whether or not the fiscal note is accurate, whether or not we can make it work like the other states, even if it's a little different? What do you think about that? Because we often see these bills, and the fiscal note, it's a really easy way to kill a bill, right? For lack of a better word, where the intent of the bill, oftentimes, whether we agree or not, is to fix a problem. So we know we have a problem. So sometimes we have to be creative how we go about finding a solution so that we could show whether it works. Will you be open to sitting down with the sponsor? And again, I apologize, I did not let you know I had that in mind. It just came to me while I was sitting here because of the fiscal note, right? In all honesty. Because it's so difficult to argue with a fiscal note like this, especially when we have the current situation, right? What will you be willing to sit down and explore it?
So as a friend of Delegate Steve Johnson, I will say, yes, I would be more than willing to sit down.
Not a friend
and
of Ashanti
I mean, I can have more than one friend. I mean, I got to make it another 70 days if I don't have more than one friend. So I will say, yes, we would be willing to sit down and have a discussion. I will point out, though, that the fiscal note numbers in the different segments is not necessarily comparable, right? So I think the MDH 109 million is addressing 1.7 million beneficiaries. The state health plan, the employee plan, that says 500,000 to $1 million, there's only a couple 100,000 at most on that plan, so it's wildly different in the size. And then there is no cost impact that is it's included in the fiscal note about the commercial market. So we don't really know, right? There are a lot more folks in the commercial market than there are in the state health plan. So if it is tailored towards the state health plan, that is an ERISA plan. We could tailor that plan to whatever we want to, and you could do a pilot pretty easily. We'd be happy to have a discussion about it.
And I'm glad you're willing to sit down, but let me just correct the record. There is 1.7 million people on Medicaid, but you're assuming that every single individual will get this benefit. And that is not the case, right? Because we don't know whether it's 10% or 5%. Right. So we're going for the worst case scenario. Right. But, so what I'm saying is, let's try to find a number, right, that may work. Like what you just stated is a possibility. But I just want the record to reflect that these assumptions are for every single member, and not every single member is it fair to say, would be getting these drugs. I don't get it, and I'm part of the, right? So.
As your friend, I would agree with you.
Thank you. Thank you. Wise men. So thank you for being willing to sit down. I really appreciate it. And you know what? Thank you, both of you, for sitting where you are and being patient with our questions, right? And we do respect your position, because we need to have cost containment, right? Otherwise, the policies go out. We know that. But if we could try to find, some compromise or a creative way to show whether it's true or not, that's all I'm asking. But I thank you both for being patient, and you're welcome here anytime, okay?
Thank you.
No matter the hat, I'm always here to help find solutions.
And no matter whether you're a friend or not. But
always
you are
a friend.
But
I'll be back in a couple bills.
Thank you so much. Let's go back to, let's do a favorable with amendment, because we did hear from the favorable, now the unfavorable. Let's do the favorable with amendment. Let's do Courtney Bergen And then we have a favorable with amendment, Evelyn Burton, which is virtual. Will you please bring her up? Yeah, Burton. And she's a friend of HGO. All right. All right. And if you wear the T-shirt, I'm a friend of HGO, you get a 10% discount. Welcome. Go ahead. We're
Bill
just
language or?
We're just funny here. Go ahead.
Thank you, Madam Chair, members of the committee. My name is Courtney Bergen. I'm an Equal Justice Works Fellow at Disability Rights Maryland. I'm also a Baltimore City resident with a serious mental illness. DRM strongly supports House Bill 382, which would help guarantee more equitable access to psychiatric medications and remove unnecessary barriers. DRM simply wishes to offer a friendly amendment to tailor the bill's coverage to serious mental illness as determined by functioning rather than diagnosis, perhaps using instruments such as the Global Assessment of Functioning or the World Health Organization's Disability Assessment Schedule. As the bill is currently written, a large number of DRM clients would be excluded from the protections, while many might be protected but not need them. So we were just thinking this might be a better way to tailor it to those who really need these protections most. And I'm really speaking to all this very personally because fail-first protocols and prior authorizations really have interrupted my own personal access to medications. A few years ago, I could not get my medications under a state-regulated insurance plan, and it caused me to have a seizure. This caused me to incur numerous costs that are far beyond what that medication would have cost me, which was a generic mental health medication, a medication that I simply couldn't access because of the formulary, a formulary that I needed because of my disability, and because of that, again, I ended up in the emergency room. This story, like mine, is not unique. My clients like this with similar experiences have these things happen every day. But again, my clients, we wouldn't be protected. My mental health diagnosis is not covered under this bill. And at the time, I had just come out of a year-long hospitalization. So it's not that my diagnosis was mild by any length. So, me eventually being able to access my medications reliably led me to be able to go to law school and get a job and work and be here before you today. So we would just ask you to issue a favorable report on this bill with an amendment just to tailor it more to the serious mental health population. Thank you.
Thank you, and thank you for your time and your advocacy. Are there any questions for this witness? Seeing none, thank you so much. And who's your friend? Where's your friend?
Dog Kira.
Okay. So we have someone virtually. Actually, will you please bring both virtual witnesses? Thank you. And thank you, everyone, for your patience. We're almost there. Evelyn Burton, I saw you. Okay, Meredith.
Perhaps using instruments such as the Global Assessment of Functioning or the World Health Organization's Disability Assessment.
Evelyn Burton, can you mute yourself or turn it off?
A large number of DRM clients would be excluded.
Evelyn. Evelyn, can you please mute yourself? Why don't you? Please mute yourself. I'm going to start with Ms. Johnston. Go ahead, Ms. Johnston.
Medications. A few years ago, I could not get my medications under a state-regulated insurance plan, and it caused me to have a seizure.
I'm sorry. Hi.
Hold on a second. Evelyn, can you please mute yourself?
What that medication would have cost me.
1 second.
Which was a generic mental health medication. A medication that I simply couldn't access because of the formulary.
Evelyn, please mute yourself. Okay. Thank you so much. Ms. Johnston?
Okay.
Will you be so kind and get started?
Thank you. Good afternoon, members of the committee. My
Good
name
afternoon.
is Meredith Johnston. I'm a board-certified psychiatrist with 18 years of experience treating severe and persistent mental illness. I'm the director of psychiatry at Healthcare for the Homeless in Baltimore, and I've been there for 15 years. I strongly support this bill, which prohibits prior authorization, step therapy, and fail first protocols for prescription drugs treating mental illness. Mental health crises require urgent action. Any delays caused by administrative barriers can worsen symptoms, can lead to unnecessary suffering and more intensive and costly interventions later. Quick and appropriate intervention can help people stay out of the hospital and not get involved with police or criminal charges for being acutely ill in public. Step therapy that requires fail first criteria can be particularly harmful for people with severe and persistent mental illness because the treatment requires highly individualized and nuanced treatment based on an understanding of each patient's history, comorbidities, and response to prior treatment. Delaying care with increased administrative burdens undermines clinical judgment. If I have a psychotic patient in front of me who has finally agreed to try a long-acting injectable antipsychotic, if I need to wait days for prior authorization, that window may close. Another example, I recently had a patient with severe tardive dyskinesia that caused significant distress. He met the criteria for Ingrezza to target his medication-induced movement disorder, but the prior authorization was declined over and over.
Can you hear me? I still hear the other witness.
Can I keep going? Okay.
Hold on a minute, Ms. Johnston.
Okay.
Evelyn, you have to stay muted until I call on you because Ms. Johnston is giving her testimony. So please keep it muted. Thank you. All right. Go ahead, Ms. Johnston.
Okay. I was telling about a patient who was denied Ingrezza over and over that would treat the tardive dyskinesia. While the reviewer was questioning the diagnosis of schizophrenia, which was very clear, but was also in the context of long-term homelessness and substance use. Patient gave up waiting for approval and he's abandoned treatment. This bill represents a crucial step towards ensuring that individuals with mental illness receive the care they need without unnecessary delays or barriers. By supporting this bill, it would be prioritizing mental health and the well-being of Maryland residents, and also affirming the importance of evidence-based, patient-centered care. I strongly request a favorable report on this bill, and I thank you for your time and consideration.
Thank you for being patient. Sometimes it happens when you do it virtually, but we try to be accommodating, so it allows you to, not come here and be able to give the testimony, so thank you. Are there any questions for this witness? Seeing none, thank you so much. You have a wonderful, blessed evening, okay?
Thank you. You too.
Let's
Take care.
see if Evelyn, is Evelyn there? Yes, she's coming back, okay. Hi, Evelyn, will you please unmute yourself?
Okay.
Thank you.
Sorry for the technical problems.
It's okay, how are you doing?
Pretty good, pretty good.
That's
I'm
good,
sorry
good to see you.
I couldn't be with you in person.
Good.
Shall I start?
Yes,
Okay.
thank you so much.
Good afternoon. I'm Evelyn Burton, the Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. As families of those with psychotic illnesses can tell you, like stage 4 cancer, which you have already exempted from these insurance barriers, psychotic illnesses also have a high risk of death. It is death by suicide. If delays in optimal medication lead to non-adherence, the risk of suicide increases 4-fold. The risk of homicide increases 15-fold. Research also finds significant increases in rates of hospitalization, ER use, incarceration, and drug use. These consequences can happen within days. My relative became homeless and suicidal after only 1 day without effective medication. Also, when insurance required a change from a brand name's antipsychotic to a generic, the result was $500,000 in ER and hospital costs, a lot of which was borne by the family. The department's testimony and fiscal note clearly only include medication costs, not the much higher costs of hospitalization. We ask for 3 amendments. 1, inclusion of hospital costs in any analysis of program costs. 2, include schizoaffective disorder, which is similar to schizophrenia. And 3, give the legislature, not the Department of Legislative Services, the responsibility for deciding continuation of the law. Otherwise, abruptly reinstituting these barriers on those already stabilized is tantamount to a death sentence for suicide by some and incarceration for others. Thank you very much.
You did on AOT last year. You were instrumental in getting that bill through. It took us 24 years, but you worked really hard on it. And all those days you came to talk to all the legislators in the House and the Senate paid off. So thank you very much. Are there any questions for this witness? I don't see any. Evelyn, you have a wonderful, blessed evening, and thank you. Great to see you, okay?
Thank you. You too.
Take care of you. Bye-bye.
Right. Bye-bye.
Bye-bye. All right, so we have left 2 witnesses, Laura Willing and Nicole Granner, on this bill. 2 witnesses, will you be so kind and come up? Thank you very much. And Ben, Stefan, I see you there. I'm going to change the order, and we're going to take House Bill 11, Delegate Semple Hughes, after we're done with this, Ben, so that you don't have to wait all day. And Delegate Martinez was very kind to allow us to do that. Good afternoon. How are you? Good. Will you be so kind and bring the microphone closer to you? Thank you very much. And you can get started.
Thank you. Chair Pena-Melnick, Vice Chair Cullison, and members of the committee, thank you for the opportunity to provide testimony in favor of House Bill 382. My name is Dr. Laura Willing, and I'm a psychiatrist at Children's National Hospital. Children's National strongly supports House Bill 382. The benefits of this legislation include reducing provider administrative burden, ensuring patients with serious mental illness are given the most effective treatments, and eliminating excessive delays in care while patients wait for approval. Children's National has seen an upsurge of children and adolescents presenting with serious mental illness, such as depression, bipolar disorder, and psychosis. Sometimes we are limited in the treatments we can use due to prior authorization and step therapy requirements. According to a study conducted by the American Medical Association, almost 90% of physicians surveyed reported that prior authorization leads to higher overall utilization of healthcare resources, while 69% reported ineffective initial treatments due to step therapy requirements. I recall a family of a young person who was not able to pick up a much-needed prescription after being hospitalized for serious safety concerns due to mental illness. The prescription required prior authorization, and because they had not yet established care with an outpatient psychiatrist, they came to the Children's National Emergency Department for help getting the prescription filled. In addition to the detrimental impact to the patient, these types of roadblocks can lead to overutilization of the emergency departments, contributing to higher emergency department wait times for other patients. These barriers to care may also result in extra office visits to cross-titrate medications, decompensation of serious mental illness, and even hospitalization. Children's National strongly supports House Bill 382, including for children and adolescents, and believes it would have a positive impact on our patients and our families. Thank you.
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the committee. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. Our 87 member organizations serve the majority of individuals who access care through the public behavioral health system. I'm here in strong support of House Bill 382. As you've heard, this prohibits the use of prior authorization requirements, step therapy, or fail-first protocols for prescription medication used to treat mental health conditions including bipolar disorder, schizophrenia, major depression, post-traumatic stress disorder, or medication-induced movement disorder associated with the treatment of these serious mental illnesses. Before joining CBH, I worked for a large behavioral health provider in Montgomery County, and I've seen firsthand how high the stakes are for these individuals who may rapidly decompensate without the medication they need to stabilize their symptoms and improve their levels of functioning. While the decompensation may take days, the return to a baseline level of functioning takes often much longer, weeks and even months. And it requires much more intensive supervision, including hospitalizations and emergency department visits. While there are various medications in a specific category that may be equally effective in treating a diagnosis, there's wide variability among these medications as to their side effects, which can include liver damage, extreme weight gain, and sexual dysfunction. When these individuals do not have access to medication whose side effects they can and will tolerate, there is a significantly higher risk of non-adherence to the prescribed medication regimen. There's a high correlation between non-adherence to medication and utilization of high-cost care, such as emergency departments, visits, and inpatient hospitalizations. And requiring a person living with a serious mental illness to fail first on medications may result in hospitalization, job loss, and the loss of employer-based health insurance. House Bill 382 is a critical consumer protection bill, and we urge a favorable report. Thank you.
So I have to say, Ms. Granner, that you have big shoes to fill.
I know. I'm well aware.
You are the new Lori Doyle. And Lori, for
I
those
try
of
not
you
to
that
say
don't know,
that.
Lori retired. This is the first time you're in our committee, correct?
Yes, ma'am. Yes, ma'am.
And she was amazing. I'm sure you are amazing as well.
Thank you.
And we look forward to working with you.
And I as well.
And welcome. If there's
Thank you.
anything we can do, please let us know.
I definitely will. I appreciate it.
Are there any questions for this panel? Oh, any questions for Ms. Branner? That's what we do for new people.
I'm ready. Have at it.
Thank you for reminding me, Delegate Taveras. But on a serious note, there are no questions. Thank you for your testimony. And for the doctor from Children's, thank you so much for the work you do, okay?
Thank you.
You have a wonderful, blessed evening. And this actually concludes the bill hearing on House Bill 382. And is Delegate Semple Hughes here? She is? Okay. If she's out there, will you please? Thank you so much. What is it? Okay, thank you. So we have, for the committee, for planning purposes, we have 2 bills left, and they have a total of 27 witnesses, but you see how it goes quickly anyway, right? At 4 o'clock, I have to get up to have a meeting with the Speaker's office. Vice Chair Collison will lead it. Is she here at all?
She's not. There's a couple people calling her, but she's not out there.
Okay, well, okay, so you know what we're gonna do? We're gonna continue. So let's go forward with House Bill 383, so we can keep going. Okay. And House Bill 383 is Delegate Martinez. It is Maryland Medical Assistance Program and Health Insurance Coverage for orthosis, so everybody can move act. All right. Everybody.
Yeah. Okay.
Delegate Martinez, you can get started.
Thank you so much,
You're welcome.
Madam Chair, Vice Chair, and colleagues of the House Health and Government Operations Committee. For the record, I'm Delegate Ashanti Martinez, here to present House Bill 383, the Maryland Medical Assistance Program and Health Insurance Cover for Orthoses, also known as the So Everybody Can Move Act, Part 2. You probably remember the name because last year, I think it was voted at the end of the year as the most popular bill that came before this committee, where we now allow for Marylanders to get activity-specific prosthesis and have that deemed medically necessary. You probably remember Nathan, the championship Little Leaguer, who was here to advocate on the bill. And this year, we're coming back for the second piece of what the original bill was before it was amended, which is the orthoses. like I said, orthoses are the second part of the bill that was left out, and so which left a gap in coverage. And orthoses is simply a brace or band that helps keep the prostheses in place. And as it currently stands, insurers are not fully required to cover this, and therefore we want to pass this bill because it is necessary that individuals have access to both the prosthesis and the orthoses. It is estimated that about 41,000 Marylanders will be in the need of orthoses by 2025. And with the passage of this bill, we would provide coverage for thousands of Marylanders that currently are having to pay out of pocket for these medically necessary devices. I urge the passage of this bill because we want to make sure that we're doing everything we can for those that need medically necessary devices, and this bill does just that. On the panel with me today, I have both patients, practitioners, and really passionate advocates. In your package, you will notice a letter from the health department because one of the things that our original So Everybody Can Move bill had was a study for this piece because we knew there was a cost that would come along with it. You'll hear in the testimony some of the discrepancies that we are working through with the department around that cost study, just because we have a difference in how we view the study should have went and what they are saying, and so we are still working those issues out. And then you'll also see one unfavorable from my friend Matt. But with that, I urge a favorable report for House Bill 383.
We'd like to go next, Delegate.
We're going to have John go next.
Let's do it.
Good afternoon. Sorry. Madam Chair, Madam Vice Chair, members of the committee. As many of you remember, my name is John Edward Heath. I am the CEO and founder of the Adaptive Athletics Foundation of Maryland. I am also a retired professional athlete, retired Marine Corps Staff Sergeant, and most importantly, I am an Annapolitan and Maryland native, okay? To shake the room a little bit, I don't know if you guys know, Maryland was voted #2 happiest state in the United States, so let's keep it with football, crab cakes, and Old Bay. But that being said, if you guys don't know my story, I was a limb salvage prior to my amputation, okay? And in service, I was given the super brace, which is called an IDEO exosim. With that super brace, I was able to continue serving, and I was able to proceed in my life. Okay, without that, my mental health would have deteriorated and it wouldn't have been possible. Now, when I left service, there was a gap prior to my retirement and VA benefits hitting, and I broke that specific brace. Insurance did not cover it. If it wasn't for ESPN reporter Kenny Mayne, at the same time that Commanders quarterback Alex Smith got injured, they paid $14,000 for that brace. And had it not been that, I would not have competed as a professional athlete. So just the psychological effects of someone who has a limb salvage or has a disability that requires that kind of prosthetic, that's what I'm advocating for, because I have the unique story of speaking as somebody who used an AFO, was a limb salvage. I am now an amputee. I use prosthetics. This is a non-negotiable for the disabled community. But overall, we have set the standard in the United States as the 6th state that passed this legislation on prosthetics so everybody can move. With that, I truly urge every single one of you guys, I want to thank you guys for the support last year. And hopefully, you know, I am a friend because I'm wearing red. But again, thank you guys for this opportunity to hear us out. And hopefully you guys vote favorable. Thank you.
And thank you for sharing your story with the committee.
Thank you, Madam Chair.
You're welcome.
Madam Chairman, Vice Chair, and Committee, my name is Dr. Humayra Abawi. I'm a podiatric surgeon that's been serving Marylanders for the last 15 years. I have a very unique practice where I treat neonatal, pediatric, adult, and high-risk patients, both in the civilian, active duty, as well as the veteran population. I'm here as a clinician, as a provider, and as a friend to ask you to be full support of this bill and to allow Marylanders coverage for not only daily but active wear for both those who have neuromuscular as well as musculoskeletal disorders for both the acquired and congenital deformities. Shoes for daily wear and for daily wear in athletics vary. For daily wear, we rely on it for support for standing and walking. For high impact activity, we rely on it for shock absorption. For high-risk patients, those with deformities, neuromuscular disorders, or diabetes, it's critical for these to be able to be adaptable for between the insoles of the shoes that you wear to come to work to the insoles you wear to keep your A1C down, to keep your weight down, and keep your doctor out of your ear. Not all shoes are created equal, and not all insoles are meant to be for all shoes. I'm a hospital-based podiatrist, and I'm proud of it, and I've been able to serve and see unfortunate things for those who are high risk. And time again, I've seen those who come in for wounds, to admissions to ICUs, needing IV antibiotics, all because I had an ill-fitting shoe or a mismatched pair. These would lead to amputations, unfortunately done under my hands, due to save the patient's life. Investing in custom motor orthotics for preventative measure is critical. Just like how health insurance have now moved to covering gym memberships, this is just an additional adaptive, more proactive approach to supporting those who want to keep their comorbidities at comorbidity list to a minimal. I urge you to support this bill because it's not a luxury, but more of a medical necessity so that those Marylanders can keep healthy, independent, and stay active. Thank you.
Madam Chair, Madam Vice Chair, members of the committee, good afternoon. My name is Shane Horn. I'm 36 years old. I'm a T6 paraplegic. I moved to Maryland in 2010 to join the Baltimore City Fire Department. And before my injury, I lived a very active lifestyle. I played ice hockey. I went to the gym. I traveled as much as I could, and I spent as much time as I could outside with my dog and my wife, Lisa. On November 25th, 2018, I fell from my roof hanging Christmas lights 3 days before my honeymoon. I landed on my back, and I had a burst fracture of my T8 and 9 vertebrae, sending bone shards into my spinal cord. I was rushed to the hospital and taken immediately into surgery. Woke up after surgery, and Lisa was in the room with me. We shared an incredibly emotional moment where I broke down in tears because I thought my life was over, that I'd never be able to work the job that I loved again, and all the activities and outdoor lifestyle that I lived would be coming to an end. I fell into a depressed state, and my mental injuries were just as severe as my physical ones. I spent 5 days in the hospital, 4 weeks in inpatient rehab, and was discharged to figure out how to move on with my life. About a month after discharge, I was admitted into an inpatient spinal cord rehabilitation center in Baltimore, where, among other things, I was introduced into the world of adaptive sports. I've tried everything under the sun, from sled hockey to basketball to mountain biking. Two sports that really stuck with me are CrossFit and hand cycling. I'm gonna have to pare down a little bit because I'm running out of time. Okay, I appreciate that. Being active again cleared my mind. It helped me return to the mindset I had before I was injured, while also giving me the confidence to do things I never thought I would be able to do again, such as traveling and advocating for disability rights. Now, a little over 6 years later, my injury has led me to things I never thought I would have done. Competed in numerous adaptive CrossFit competitions, hand cycled in 6 marathons, traveled the world, and remained a full-time employee with the city of Baltimore. I have a pair of custom knee, ankle, and foot orthotics that I use for therapeutic purposes for standing and walking. However, I am not able to use them in an active lifestyle capacity. One thing that I could benefit from for a pair of different orthotics is when I'm in my hand cycle, I have no control of my legs, so my feet rotate inwards, and sometimes my heel strike the spokes of the front wheel. That can be dangerous. Just to tie it all together, exercise is medicine. Being physically active was a return to normalcy that I needed to live a fulfilled and meaningful life. Medical equipment is expensive, and without grants or crowdfunding, a lot of people are not able to afford what they need. This bill is an incredible step in the right direction to let the disabled community know that their health and well-being matters, and they are capable of being active without having to worry about damaging everyday medically necessary orthotics. I appreciate your time and listening to my story, and I appreciate you considering all the benefits that this bill would achieve. Thank you.
I'm so sorry that that happened to you. I do want to thank you for sharing your story with the committee, and I am so glad that you're with us today.
I appreciate it. Thank you.
You're welcome. Next, please.
Show and tell, sorry.
All right. Madam Chair, Madam Vice Chair, and members of the committee, my name is Cheryl Sachs, and I thank you for the opportunity to comment in favor of House Bill 383. I'm a certified prosthetics and orthotics practitioner who provides care for patients, and I have been doing so for over 13 years. I evaluate my patients for custom orthoses daily, and am responsible for coding and providing medically necessary justifications for each aspect of their orthotic intervention. Many of you have likely seen the cost study report completed by the Department of Health and Healthcare Cost Commission with regard to this legislation, and I know that you've looked at the fiscal note assigned to this bill. However, there are 3 key reasons why you should question the information provided. Number 1, irrelevant billing codes. The projected cost of House Bill 383 is based on 258 billing codes. However, over 30% of those codes are not codes for custom orthoses for physical activity, and therefore are not relevant with regards to the proposed coverage from this bill. Number 2, overstated projections. The utilization projections in the report, which also impact cost, are based on an actuary report from Minnesota. However, this report calculates cost assumptions in Minnesota for coverage for insurance fairness for prostheses and orthoses, activity-specific prostheses and orthoses, along with shower and bathing devices. House Bill 383 is only requesting the additional coverage for activity-specific custom orthoses. At least 20 of the 26 codes utilized to complete the Minnesota report are irrelevant to this legislation. And number 3, contradicting data. The report states that the number of individuals who utilize the 258 specified codes increased by approximately 1,000 individuals from 2022 to 2023. However, the actual number of units of service billed decreased by 5,600 units, and the amount of expenditures associated with those units decreased by just under $200,000. Despite the decreases above, the study projects an increase of 1,700 service units and a resultant $1.1 million in cost prior to any implementation of the legislation for the additional custom orthoses for physical activity. As you consider this bill, I urge you to consider the overwhelming positive impact it will have on your constituents and understand that the costs to do so are significantly overstated. You can find additional details in both my written testimony as well as the information submitted on behalf of So Everybody Can Move. It's for these reasons that I urge you to support House Bill 383. Thank you for your time.
We really appreciate it and for the work that you do, okay? I'm going to open it up for questions now. Are there any questions for the sponsor and his panel? Okay, Delegate Rosenberg.
You said it in your testimony, but what's the scouting report for the young man who testified last year? How's he doing?
Yep, so Nathan, again, who testified last year, is in the process of getting his sports leg. I actually saw him about a week and a half ago, and he's now as tall as I am. But he's doing fantastic. And I think some of you might have seen that he and another young man got to throw out the first pitch at an Orioles game last year in honor of Limb Loss and Limb Difference Awareness Month. So he's doing fantastic. Thank you for asking.
Thank you. I was probably there.
Thank you, Madam Chair, and thank you, Delegate, for bringing us this bill, and Mr. Heath and Mr. Horn, thank you very much for your stories, your successful stories. And Mr. Heath, I agree, Maryland is a great place to live. Dr. Sachs, so these are orthotics, correct?
Yes, they are.
Can you give me a price on this?
I can actually. If you bear with me one moment. I highlighted it so I'd be able to find it.
Don't worry, take your time.
Thank you.
Because you didn't know the question was coming, so.
No, I didn't wonder.
There's no way to
So the information I can provide you is based off of the Medicaid 2024 fee schedule.
Okay.
I believe, I'm almost there. So the orthosis that you're holding in your right hand is what we would call a custom molded supramalleolar orthosis. That orthosis for a single orthosis would be $550 approximately. Okay. Now built into that cost includes clinician time, the casting and measuring process, the fitting of the orthosis, education, and up to 3 months of any repairs or adjustments needed. So it's kind of like a lump sum associated with it.
That's a total cost.
Correct.
Of this.
The orthosis that you're holding in your left hand, well, it looks like there's a foot orthosis in there too. But the larger orthosis, orthosis that you're holding is called a custom molded articulated ankle foot orthosis. That orthosis, the base fee is $665.
And could you tell me what this orthotic allows an individual to do that they couldn't do with a regular orthotic that they might get that would be paid for?
Yeah,
already?
absolutely. So, and one of the things to mention is the orthoses that are being passed around and that you're holding are currently orthoses that we are able to provide patients for everyday use. So the articulated AFO, for example, if that's a pediatric orthosis. So sometimes we have patients who toe walk. When they walk, their heels don't touch the ground. Sometimes there's an underlying diagnosis surrounding that. It could be cerebral palsy, for example. And sometimes it's idiopathic, which means we're not really sure why, but that's just how the child walks. So that orthosis, because it has an ankle joint, it allows for movement to allow for the ankle to flex forward, dorsiflex, but there's a rigid block that prevents the child from being able to go up onto their toes. So it's training them to have increased balance. A lot of these individuals who are toe walking are at an increased risk of falls, especially over uneven terrain, such as playing on the playground with their peers.
Thank you very much for your help.
Absolutely. My pleasure.
Thank you, Madam Chair. This is a little bit of a follow-on to Delegate Cullison's. If you could just talk a little bit about some of the things. Again, we saw mostly things for small people. Can you talk a little bit about the types of activities that who benefits in the small person space, and what types of things that it allows them to do that they might not otherwise be able to do?
Yeah, absolutely. Thank you for the question, Delegate. And I can speak for both adults and for children. So again, this legislation is not just for lower extremity custom orthoses. It's for really any type of custom orthosis, including arm orthoses, though from a clinical standpoint, we really are focused more on lower extremity just because walking and falls is something that we're all really concerned about. So for a child, for example, who I mentioned toe walking, sometimes with their weakness, even allowing an articulation is not going to give them enough stability. So I think there's a solid ankle AFO that's being passed around somewhere, but that's a solid piece of plastic. And that's essentially holding the child's foot and ankle in all three planes of movement. So for someone who doesn't have like quadricep strength or hamstring strength, whose knees are at risk of buckling, we'd put them in a more solid design AFO for everyday walking to prevent them from falling. However, if that child wanted to participate in dance class, for example, they're unable to do so in such a rigid piece of plastic because they don't have the movement at their foot. So dance is an example where you would want increased movement, but you wouldn't want that movement for everyday walking. I passed around the pediatric races because those are some of the fun, cute ones, but we don't want to leave out the adult population as well. So there are individuals, and you heard Shane's story, and these are individuals who may not need AFOs or custom orthoses as a child, but as an adult they might need one, whether they've had an injury, they have spinal stenosis, which again, narrowing affects nerves in your back, controlling foot drop. You've had a stroke, you're diagnosed with multiple sclerosis. A lot of these individuals would benefit from a custom ankle foot orthosis for everyday walking, but again, depending on how that orthosis is fabricated, it may not provide them enough movement. And we can certainly pass some of these around as well. But this is, again, an example of a custom ankle foot orthosis. It provides a spring mechanism when someone is walking. But if this individual wanted to go to the gym and try to do squats to increase their strength, they wouldn't be able to do so in this orthosis without breaking it, for example. I'll let you hold that one.
Again, I have to
Certainly.
step out for a meeting, but my vice chair will continue. Delegate Semple Hughes, after we're done with this, we'll call your bill. Thank you so much. And thank you to everyone that is being patient and waiting, okay?
Thank you, Madam Chair. And this is, again, just an example of another custom orthosis. This actually attaches to the outside of the shoe, but this orthosis, you can even see, is already kind of fashioned in such a way that would allow for bending of the knee, that flexion. So this would not necessarily be appropriate for everyday walking and everyday use, but it would allow for increased physical activity, such as squatting at the gym or someone who might want to go rock climbing. Thank you.
Thank you.
Delegate Taveras.
I'm going to direct this to Ms. Sachs. Thank you for your presentation, and well, thank you to all of you for coming here and doing what you do, because I know that last year's testimony was very touching, so much so that you were able to pass the bill. With a few caveats and a few exemptions, and this is the revisit. Is it possible for you to revisit the areas that you see as deficient? We just saw the fiscal note. This is a tight fiscal year. You highlighted some discrepancies between what they're citing and what you're citing. Is it possible that, how do you consider a fix?
Thank you, Delegate, for your question. We have a meeting scheduled with the Department of Health this upcoming Tuesday to discuss exactly that.
Do you have some recommendations on that?
Yes, so the first recommendation is to recalculate the fiscal cost by removing the extraneous codes. So over 50 of the codes that were used for the calculations for the cost report are not for custom orthoses. They include multiple prefabricated orthoses, which are not part of this legislation. They also include orthopedic shoes and addition billing codes for those shoes, which again is also not part of this legislation. So we're optimistic that there will be a significant decrease in those devices because utilization tends to be higher. We don't know exactly what the utilization is per code though, and that's some information we hope to get from them as well. The other thing that we are in the process of looking at is trying to get actual data to help us understand what the projected costs will realistically be. As of now, again, you heard John Edward Heath discuss this, but Maryland's at the forefront of this movement of increasing care for physical activity, orthoses, and prostheses. So to date, there's only one state that has already implemented coverage for activity-specific orthoses. And we are in the process of trying to get their data. So we have some real numbers that we can use to try to shape this report, since the report is based on an inaccurate actuary report from another state.
Thank you.
Thank you.
Thank you, Delegate. Any other questions for this panel? Then I thank you all very much for your time and your testimony today and your patience to getting to this place in the afternoon. I'm going to call another panel of favorables. Charlie Kelly, Audrey Sellers, Matthew Mitchell, and Madeline Goldberg. Okay, and go ahead and start, but please bring the mic up as close as it can go so that we can hear you.
Madam Chair, Madam Vice Chair, and members of the committee, thank you for your time today. My name is Charlie Kelly. I'm a certified orthotist prosthetist practicing in Annapolis. I'm here today to express my strong support for HB 0383, the So Everybody Can Move Act, which mandates you expand coverage for orthosis under Maryland Medical Assistance Program and private health insurance plans operating in our state. This vital legislation represents a significant step forward, ensuring that all Marylanders, regardless of their economic or physical condition, have access to orthotic devices that they need to lead full and independent lives. Orthoses are more than just medical devices. They are lifelines for individuals managing neuromuscular and musculoskeletal disorders or acquired conditions. By mandating coverage for custom orthosis, components, repairs, and necessary replacements, HB 0383 addresses critical gaps in accessibility and affordability. For the patients, it means the ability to maintain mobility, regain mobility following life-altering events, and as practitioners, we have a direct influence on the patient's mobilities and fostering their independence and improving their overall quality of life. HB 0383's key provisions are forward-thinking and comprehensive. Two important provisions are the coverage for custom orthosis related component for physical activity when medically necessary. This ensures that patients are not left without critical care due to wear and tear to their device or changes in their medical condition, or using an inappropriate orthosis for physical activity. It addresses the prohibition of cost barriers. The bill prevents insurers from imposing higher copayments and annual lifetime dollar caps to orthotic coverage compared to similar benefits. These provisions will empower individuals to regain and sustain their physical functionality, enabling participation in daily activities, essential job tasks, and recreational pursuits that contribute to the overall health and well-being. I urge you to support HB 0383 and its goal of creating a Maryland where mobility, independence, health, and equity are attainable for everyone. Thank you.
Next.
I'll go. I'm Audrey Sellers. Thank you to Madam Chair, Madam Vice Chair, and the members of this committee. I'm Audrey Sellers here on behalf of Disability Rights Maryland, or DRM. DRM is the protection and advocacy system for the state. I wear orthoses, so this is an issue close to my heart. Orthoses enable me to fully participate in community life, professionally and socially. I want to share a little bit about their importance. Without orthoses, I would never have made it here today to testify on behalf of DRM. Without them, I would be forced to choose between staying at home or using a wheelchair. Orthoses allow me to engage in activities that make life worth living, things like hiking with friends, playing games such as tennis, and walking long distances around my home, for example, to the coffee shop. Recently, I started doing CrossFit with the assistance of the stability offered by my orthoses. Engaging in this exercise has improved my physical fitness and confidence and made it safer for me to walk overall. Without orthoses, I would not have made the gains I've made through CrossFit and other exercise. The only problem is that because my braces are for everyday use, I'm risking breaking them every time I use them. Orthoses are life-changing devices that every Marylander with a qualifying disability should have access to so they can lead a full life with purpose. DRM supports HB 383 and encourages you to vote favorably. Thank you for your time.
Mr. Mitchell?
Thank you, Madam Chair, Vice Chair, and members of the committee. I'm here to just share my story today. My name is Matthew. My story starts with a fracture to my L4 vertebrae on my spine, causing life-changing damage to my body. I woke up in a hospital completely unable to move my left leg or my foot. Couldn't wiggle a toe. Came with immense pain that I couldn't escape. After 2 weeks, I stood for the first time. By clenching onto the walker with all my strength and 8 nurses crowded around helping me, I stood shaking for no more than 15 seconds before collapsing back on my bed, drenched in sweat. The bottom of my feet felt like rubber and I was frail. Then I gradually worked my body by standing and sitting. I finally, after a month in the hospital, could take 15 steps with a walker and an assistant before completely being depleted physically with jolting pain from my back down to my right leg from overcompensation from a weakness in my left. Over the next 2 months, I walked every day, no more than 8 parking spots in a parking lot. Imagine that, 8 parking spots, walked that distance and walked back, and that was it. Too embarrassed to be using a walker at the time, I prematurely started using a 4-prong cane. That's when I finally met Charlie, and soon after my first non-custom AFO. It was fantastic. I could now walk with a stiff brace to help my drop foot to walk up to a full mile. However, in excruciating pain. After lots of practice with the non-custom AFO, I gained more and more. After 4 months of the non-custom AFO, it was recommended that I receive a custom AFO because it had better capabilities to further my progress. After receiving my new custom AFO, I went from mustering 1.5 miles max to quickly 5 miles in one trip, slowly taking on hills, to weeks later making a 7-mile hike, to finally being able to enjoy a day trip and walk 10 miles around New York with my father, to my new personal best, a 12-mile hike with parts, can I finish this? I'm sorry. To my new personal best, a 12-mile hike with parts of it being on a beach. With the right custom AFO, I wouldn't have the ability but if I to run again. But if I try to run in my current AFO, it would break, leaving me unable to walk. The only thing preventing me from being as physically active as I was before my injury is the lack of insurance coverage for a custom physical activity orthosis. My incredible progress is owed almost entirely to the custom orthotic that I received and my orthotist, Charlie Kelly. Please help me continue my recovery by passing the House Bill 383. Thank you so much.
For your story. Ms. Goldberg.
Madam Chair, Madam Vice Chair, and members of the committee, thank you for the opportunity to speak today in favor of House Bill 383. My name is Madeline Goldberg, and I am a doctor of physical therapy with a specialized focus in treating patients who have hypermobility and connective tissue disorders such as Ehlers-Danlos syndrome. Many of my patients experience significant daily challenges, including joint instability, subluxations, and dislocations, which result in chronic pain and loss of basic mobility. Maryland, like the rest of the country and world, is in the middle of a public health epidemic due to a lack of physical activity. According to the CDC, inadequate levels of physical activity are associated with $117 billion in annual healthcare costs. And when compared to their able-bodied peers, individuals with disabilities are 47% less active. House Bill 383 aims to address a part of these current healthcare inadequacies. Currently, people with Ehlers-Danlos syndrome can access custom orthoses for daily use, but when it comes to orthoses specifically designed for dynamic sport and physical activity, there is no coverage. Unfortunately, these patients are left with 2 choices. 1, not participate in physical activity, which has multiple negative implications on their social, mental, and physical health. Or 2, try to be physically active in orthoses that are not designed for such activities, resulting in injury, hospitalization, or breaking of their orthoses. In either of these situations, the state and commercial insurance endures tens of thousands of increased costs per individual. By passing HB 383, we can ensure that all Marylanders, regardless of their disability, have access to the necessary equipment to stay active, healthy, and engaged in their communities. Not only will this improve their quality of life, but it will also reduce long-term healthcare costs by encouraging preventative care through physical activity. Thank you for your time and consideration.
Thank you. I want to thank the entire panel for your personal experiences and stories. And Dr. Kelly, thank you for helping Mitchell too, or Mr. Mitchell. Questions for this panel? I do have one, Mr. Mitchell.
Yes.
To the extent that you want to answer this question. Did you get any financial assistance in paying for your custom orthosis?
No.
No, so you had to pay completely out of pocket?
The non-custom orthosis was helped. I got help with that.
Right.
And then I had to wait until the start of the new year to get my new custom brace. And then they helped, I think, less with that, but they still managed to cover some of it.
So your carrier did cover part of, cover the custom partially?
Yes, ma'am.
And so you have both the
Non-custom.
The non-custom and the custom. So you have two, and you use the custom for
So-
the activity and.
Yeah, I can get up and show you. My non-custom one was kind of like a baby step. It was like riding a bicycle with tricycle with wheels on the back, and then this is more like taking the wheels off and like an upgrade. It was like kind of like I worked my way up to being able to use this brace.
And so that's a brace that goes up to your knee?
Yes, ma'am.
Yeah.
It goes right up to my knee.
Okay. Thank you very much for sharing that with us so that we can understand, because one of the questions we had last year in this bill is no one really knew what an orthosis was.
Yeah.
So you are helping us to learn and understand your stories.
Oh, they change lives.
Thank you.
Yes, thank you.
Seeing no further questions, I want to thank you all for your testimony, and we're going to go to two virtual witnesses now. Are they here?
Should I bring in both or one at a time?
Bring in Adam Lowry. Mr. Lowy?
Yep. Can you guys hear
Welcome,
me?
and please give us your testimony.
Yes, thank you, guys. Good afternoon, everybody, Madam Chair, Madam Vice Chair, and committee members. My name is Adam Lowy. I'm the president of the Maryland Podiatric Medical Association, representing over 260 podiatrists across the great state of Maryland. I'm here today to ask for a favorable outcome in support of House Bill 383 so everybody can move act. Podiatrists across the state utilize custom-molded orthotics and devices to provide significant improvements to the functional capacities of our patients. Patients develop pain, pathology, and progressive deformities from the abnormal mechanics that travel through the lower extremities that impact their lives. These limitations impact their ability to perform activities of daily living, perform rigorous work environments, and perform physical activities and exercises to maximize whole body health. With the use of custom-made orthotics, these patients can increase their functional abilities in the various fields which impact their overall well-being for the good. Individuals feel better about themselves and their lives when they can hold meaningful jobs in the community and improve the lives of the individuals that rely on our patients. These custom-made devices have profound impacts in this way. Lack of access to them would create more limitations in these categories previously mentioned. The bill will provide our patients with continued access to custom-made orthotics and devices, as well as increase their coverage to provide devices necessary to treat and correct specifically functional needs and activities. If clinicians can assist patients in providing orthotics, which will allow them to participate in whole-body physical fitness in some way, the potential health benefits would be rewarded among the patient's quality of life and happiness. Exercise and physical fitness has been shown to impact mental health and overall well-being. The MPMA has worked closely with the primary stakeholder and have submitted amendments to include congenital deformities with our written testimony. I ask for a favorable vote on this bill, and thank you guys for your time this afternoon.
I think you must have been very thorough, sir. There are no questions here, but thank you very much for your testimony. You want to bring up Kyle Stepp? Go ahead, Mr. Stepp.
Good afternoon, Vice Chair and members of the committee. My name is Kyle Stepp, and I'm a national lead for So Everybody Can Move, a healthcare and disability rights initiative. House Bill 383 is a part of this movement, and I'm here to ask for your support. At 14, I was diagnosed with bone cancer, and doctors performed a surgery called limb salvage. But instead of mobility, I was left with chronic pain and limited function caused by drop foot. A solid, rigid orthosis allowed me to walk, but prevented me from running, playing sports, and being active. My orthotist recommended a custom activity-specific device, but insurance deemed it not medically necessary. Meanwhile, my high school friends, who tore their ACLs, had health insurance, covered their surgeries and rehab so that they could return to sports and restore their full function. I wasn't even given the chance to participate. Without coverage of an activity-specific device, I sat on the sidelines, and my family couldn't afford the out-of-pocket costs, and there's no charities available. One device alone is not enough to replace what the human body can do. It wasn't until I became an amputee in 2020 I truly understood the power of mobility. Thanks to charitable support, I received a running blade and a custom cycling socket, giving me the freedom I had since I lost cancer. Individuals shouldn't have to rely on charity or beg for access to mobility devices intended to restore their function. This legislation is designed to modernize outdated insurance policies and remove the barriers that prevent individuals from experiencing full and active and independent lives. A year after implementation in New Mexico, one of the handful of states that covered prosthetics and orthotics for physical activity has shown little to no fiscal impact, according to a rate review done by the Insurance Commission. This legislation is low cost, high impact, and widely supported by medical experts like the American Medical Association, the American Orthotic and Prosthetic Association, and numerous local Maryland providers. Simply put, movement is medicine.
Thank you. Excellent timing. I bet. All across the country, right, Mr. Stepp? Questions for this witness? Seeing none, thank you very much for being here and for your work on this bill. So with that, that concludes the testimony on this bill and the work for today on this bill, 383. And we will move to the last bill of the day, which is House Bill 11. I should remember that. And this is Delegate Sample Hughes, Health Insurance Access to Non-Participating Providers, Referrals, Additional Assistance, and Coverage. And please bring your panel up, Delegate Sample Hughes, and welcome back to HGO.
Thank
Good to see you.
Good to see you too. And when you were just getting ready to say this ends the work of the day, I said, oh no. A panel. Okay, while they're gathering, I'm gonna go ahead, because I know you're excited for this to be the last bill of the day. So good afternoon, Chairwoman Pena-Melnick, our Vice Chairwoman Collison, and all the members of the HGO. I am Delegate Sample Hughes, and I'm here to ask for your support for House Bill 11. Public health. Oh, thank you. I miss you all. And public health insurance access to non-participating providers, referrals, additional assistance, and coverage, a mouthful. But the passage of House Bill 11 would solidify our commitment to Marylanders with private health insurance who are seeking mental health and substance use disorder treatment from having to pay a higher cost when their insurance network is inadequate. As a former member of HGO, I too, like yourself, intimately know that we do not have a plethora of mental health and substance use disorder services at this time in Maryland, and even nationwide. It's still a struggle. But our team has done the work to reduce the barriers for as much as we can. In legislative session 2022, where this bill and this body voted unanimously to make certain that we could open up and have additional access for Marylanders. We've done the same with House Bill 11. We've worked diligently and have brought everyone to the table, consumers, carriers, and then certainly the Maryland Insurance Administration. Those meetings that were held, they helped us tighten up the language for the bill by way of addressing a few things. Our goal today is to, number one, remove the sunset that is due to expire on July 1st, 2025, remove the $150,000 fiscal note. I'm sure you're probably excited about that part, but to remove that. And the reason being is because, again, those conversations with all partners allowed us to understand that this bill, House Bill 11, is not the vehicle for us to address the formula for reimbursement rates. That's a subject that really kind of needs to stand alone. But we're not saying that it isn't important, because it's extremely important to get where we need to be in our mental health community. The other area to highlight is that we want to make sure that we remove the barriers of utilization, specifically making sure that the consumers are not required to go beyond what they would be required for a covered benefit. And we don't want the provider to require them to pay additional fees to get these services. But as it stands right now, under state law, Marylanders who cannot get access to healthcare services without unreasonable travel or delay may request approval from their carrier to go out of network. What you will hear today from a couple of witnesses is that how important this is for not only themselves, but their loved one, to make sure that I can seek the services, that I'm trying to figure out what's going on, but then also to maintain the treatment and not have so many barriers. Lastly, I'll just highlight is that over the years, and we can look through research, that not having the proper mental health support, it can cause an array of challenges in your personal life, your professional life, and so on and so forth. And so we don't want to hinder any additional barriers. And at this time, I would like for your favorable support on this piece of legislation so we can fix some of these issues here in Maryland. Yes, we have a long ways to go, and you'll hear from the carriers today that we're working together to get to that end and to make sure that our Marylanders are obtaining the support that they need for themselves and their family members. And so again, thank you for your time, and look forward to you asking us any questions.
Thank you. Who would you like to go next?
Deb will go next.
Good afternoon.
My name is Deb Steinberg, and I am a senior health policy attorney at the Legal Action Center, and we facilitate the Maryland Parity Coalition. We strongly support HB 11, which would ensure we do not roll back critical consumer protections that ensure Marylanders can access mental health and substance use disorder providers at no greater cost when their insurance networks are inadequate to meet their needs. Maryland carriers have taken some steps to improve their networks of behavioral health providers. However, many Marylanders still cannot access the care they need through their insurance. Maryland ranks 4th worst in the country for how often people have to go out of network for behavioral health office visits compared to medical office visits. This tells us that provider shortages are not the only problem. Many people are getting care, it's just not in their insurance networks. And when that happens, they should not have to pay more for that treatment than they would if they saw an in-network provider, on top of the premiums they are already paying their insurance companies to get affordable and accessible care. Maryland's balanced billing protection is modeled after the National Association of Insurance Commissioners Model Act on Network Adequacy, which has been adopted in some form by at least 26 states, including Maryland's neighbors, Delaware, Virginia, and West Virginia. Marylanders deserve no less, especially amidst the ongoing overdose epidemic and mental health crisis. We've gained valuable insights since this law was originally passed in 2022 from Marylanders who've taken advantage of this protection, as well as those who have tried but been unable to do so. HB 11 makes several minor changes that would remove additional barriers that Marylanders have identified. These changes provide greater clarity to consumers on what constitutes unreasonable travel or delay, ensure people can access a provider who can make an appropriate diagnosis, establish consistency on the assistance carriers should be providing, and eliminate additional burdens that would not apply if people saw an in-network provider. We've worked with the MIA and the carriers to tighten this language over the past few weeks, and we are happy to continue to do so to ensure the law can achieve its purpose. Thank you for your time, and we urge a favorable report.
Thank you very much.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland here in Yeah, it's me again, last time today, the last bill, right? But here in support of House Bill 11, and again, speaking on behalf of the Maryland Behavioral Health Coalition, who has prioritized this bill too, asking you to please reauthorize and make permanent these important consumer protections. And the reason is simple. And despite all the efforts, things that the legislature has done, the MIA, advocates, carriers have done on their own, Marylanders with commercial insurance still, to a large extent, cannot access in-network behavioral health care when and where they need it. Like Ms. Steinberg said, Maryland ranks 4th worst in the nation in that measure. And that's from a 2024 National Independent Study yet another national independent study. I'm starting to feel like a broken record here. When I was here supporting the bill that authorized these protections initially in 2022, I cited familiar findings from a national report published in 2019, which itself echoed the findings from a national report published 2 years earlier in 2017. And so, like I said, I know all of us, the advocates, legislators, the regulators, the carriers, are all working to address these network adequacy issues. But until we really get a handle on it, it's the Marylanders in need of behavioral health that are really bearing the burden and feeling the pain. They're the ones who are going to be forced out of network and to pay high out-of-pocket costs if they can even afford it. Some are going to, not be able to afford it and forego treatment altogether. And so until we find a solution, I urge you to pass House Bill 11 so that Marylanders are held financially harmless when forced to go out of network for needed care. Thanks very much.
Madam Chair,
If you could put the microphone closer to you, because Delegate White Holland will really love it for you to do that.
Is this a bit better?
Yes.
Okay, great.
She's saying yes.
Well, Madam Chair, Madam Vice Chair, and members of the committee, thank you for the opportunity to testify today in favor of House Bill 11. My name is Madison Harden, and I'm a student in the Public Health Law Clinic at the University of Maryland School of Law. And now Maryland has made significant progress in expanding healthcare access with an uninsured rate of just 6%. However, insurance coverage alone is not guaranteeing access to care. Many Marylanders who are insured still face significant barriers, especially in behavioral health care. House Bill 11 is a necessary step to sustain and build on Maryland's progress by repealing the sunset provision. During my time as a legal intern researching this issue, the data on access barriers was very clear. First, Marylanders are still struggling to access substance use disorder services. Insurance companies' 2024 network adequacy reports confirmed that many plans failed to meet the time and distance standards for several substance use services. Several plans did not meet access metrics for addiction medicine providers, opioid treatment services, and substance use disorder residential treatment facilities. And this access crisis is supported in the broader data. In 2022, 80% of Marylanders in need of substance use disorder services did not receive them. This is especially concerning because overdose-related deaths have increased by 300% since 2016. Second, mental health care access is equally concerning in Maryland. A third of adults cannot afford the mental health care services they need. And as others on the panel have reiterated, Marylanders are seeking out-of-network care for mental health services far more often than they are for other medical services. Our state ranks second worst nationally for going out-of-network for psychologist care and fourth worst for psychiatrist care. House Bill 11 is the most immediate and effective solution to closing these gaps. It ensures that Marylanders can continue to access behavioral health care now when they need it most. Making this measurement permanent is essential to keeping Maryland's progress on track and ensuring that insurance coverage truly does mean access to care. I respectfully urge a favorable report for House Bill 11. Thank you.
Yes, please.
Thank you.
You're welcome.
Hello, Chair and members of the committee. My name is Ashley Toller, Policy and Advocacy Manager with Maryland Coalition of Families. I'm here to testify in favor of House Bill 11 and to uplift family voice. When insurers do not have adequate networks, Marylanders should not have to pay more to go out of network to receive mental health and substance use services. A mother shared, if House Bill 11 is not passed, then my ability to access providers would be limited, either through access to care or because of cost of treatment. Finally, she states, the cost of care for these children and individuals with behavioral health issues is limited to their psychiatrists and therapists, but they often need additional therapeutic support services. Many families we serve spend hours on the phone during the day, over weeks and months, if not longer, trying to find a provider in network when seeking services. They are faced with many barriers. During this time, their loved ones' needs continue to go unmet, ultimately prolonging care. This affects not only the child or individual, but affects the family as a whole. This mother goes on to share that at the end of the year, the cost of treating my son's illness would be in the thousands of dollars between co-payments, out-of-pocket payments, emergency services, and medications. This cost would only be exponentially higher if HB 11 is not passed. The out-of-network provider protection costs are removed or services are blocked by needing referrals or prior authorizations. This mother's story is one of many, and if we want to improve behavioral health outcomes for families and children, they must be able to access the care they need sooner rather than later and with fewer barriers. We are asking for a favorable report on HB 11, and thank you for letting me testify today, and that is all.
We're now going to open it up for questions. Are there any questions for the sponsor and her panel? Vice Chair Collison.
Thank you, Madam Chair, and thank you for your diligence and persistence in this really important issue, Delegate. Have you worked with the insurance carriers on this bill? And what's your impression of where things are? Where do things stand now? I think you do have a few amendments, right?
Yes.
And
yes.
so tell me how you feel about where you are.
Sure. Yes, indeed. Thank you for the question, and thank you for acknowledging that this subject matter is a space that I'm passionate about, but then moreover that it takes years of work because we are moving in a much better direction. To answer your question with regards to the carriers, yes, we have met, as I stated earlier. It was important for me to bring everybody to the table because I wanted to get a better understanding of what has worked and what is working and what it would look like if we no longer had this for our Marylanders. So with that being said, when we met, we were first and foremost able to agree that that sunset date needed to be removed. Secondly, we were also able to speak to in a few amendments that I submitted, deal with the last page of this bill where we talked about the reimbursement formula, where they're saying that was quite concerning to them. I understood that, and so I made sure I made that change. Also, the carriers, certainly they can speak for themselves, but they were wanting to make sure that when I was asking if there would be assistance with someone who's trying to go out of network, that's not across the board uniform approach, if you will. For instance, if you're at another insurance carrier, one might help you completely to get that assistance and to navigate the system, but one might say, okay, it might not be as succinct as that. So our goal and during our meeting was to say, we want to be consistent. We want to make sure that if I change carriers, that I can still get the same level of support. So overall, positive meetings, and certainly we're open to additional conversation, but I believe it's at a posture right now that everyone is good, much in a better place than, starting out last in 2 or 3 years ago. So to that end, I think there's been good work and everybody's been receptive, and there may be some other tweaks that they may offer, but I kept them informed throughout the whole process, and as well working with the Maryland Insurance Administration to get the new tweak in the language. Same message, but wanting to make sure technical-wise things are in the same order.
Thank you for your work. I really appreciate that.
You're welcome.
She comes from HGO. That is how we work a bill here. So that's wonderful. Very well done. Delegate Hill.
Thank you, and thank you again for this bill. Delegate, I have a little confusion. We did a lot of work on parity, saying that behavioral health diagnosis and treatment should be on par with somatic health. And in somatic health, although we don't necessarily, people can't find someone within network, they don't necessarily get assistance. They generally, if they see someone out of network, those rates are based on rates that the insurers file with the MIA so that the out-of-network person can get reimbursed. It's better than being in network, not as good as what they would pay on their own. So I'm a little curious about why they're giving you a hard time about coming up with rates when they already do that for out-of-network providers in the somatic health space.
Thank you, Delegate. Are you referring to the MHCC?
Yeah, I believe.
Okay, sure. So an ideal world, this would have been resolved and decided upon a long time ago to make sure that the rates were, or the formula was already in place. But in the fiscal note that I received, because they were not aware that I had put in the amendment to remove it. But anyway, it states that they would need to add another staff person to make sure that they're overseeing this process. And so it makes perfect sense. Oh, wow.
Somebody got it. I'm standing by the.
Okay. So y'all.
It's you. It's you. It's you. Proximity. Proximity.
It's the fault of your friend, Matt.
Maybe.
He's powerful. He's powerful.
So maybe it was a sign to just go ahead and move favorable on this. I mean, let's just come on. But no, seriously, I believe that the MHCC is not at this time prepared to move in the formal process. But anyway, as a result, that's why the fiscal note came up $150,000. So I think, like I said, this is a subject that needs its sole attention. But then to get the specific formula so everybody's kind of operating. And I know, and I'm working with the carriers, that would be a difficult space to bring in new providers. And so we got to figure that part out with, I would say, with MHCC.
Any other questions for the delegate and her panel? Seeing none, thank you so much for being here, and thank you for the work of working and meeting with everyone. It just makes it so much easier, and we can, send it to subcommittee and try to get it out.
Yes, indeed. Thank you.
You're welcome. May we have, let's see, I'm going to call, just to be fair, as we do in this committee, let me call a favorable with amendment, and then I'll call an unfavorable and go back to the favorable. Our favorable with amendment, I have Kimberly Robinson and Ms. Kaufman.
I get to sit next to Dana.
Matt, you're not going to join that? Are you favorable with amendment? Oh, you're unfavorable. Okay.
He's really unfavorable unless amended, so he's technically aligned with me.
He's technically aligned with you? Mm-hmm. So then come and join the table, Matt. We don't want you to.
I just want to sit next to Dana.
No, I want you.
Who he called old earlier.
I have to apologize.
All right. I just want to see you at that table. I want you to be.
I know, I feel like I need a picture with Dana.
Go ahead. Go ahead, Ms. Robinson.
Thank you. Thank you, Madam Chair, Madam Vice Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. Here favorable with amendments on House Bill 11. I do want to thank the sponsor, Delegate Sample Hughes, who did exactly as she said. She pulled us together for a meeting, and we had the opportunity to talk across the different interests on this bill. And so with that, the amendments that she has right now have alleviated a lot of our concerns. I shared with her, we have just a couple of very small tweaks. For instance, there's a phrase treatment plan in the bill that we think could use a definition. And other than that, it's just some very minor wordsmithing. So we are very happy for the collaboration we were able to have with her working on this bill. Maryland, I know many of you saw a recent study that Maryland currently has an 18,000 mental health provider shortage, and by I think it was 2027, we'll have a shortage of an additional 14,000. Even if we had every provider in the state of the panel, we would still sadly still have a shortage. And we work very hard to grow our panel to encourage providers to participate because there is a positive financial expectation and experience for our patients because of the way policies are set up. But Maryland's law does and has provided that when someone is unable to access care, not just in this space, but in any of the many services that we cover, that there is a way that we are to go about that if we cannot meet the network adequacy standards that the law prescribes. And so it does create a cost savings for that patient. We treat them differently when it's our inability to provide them in-network care. Delegate Hill, that goes somewhat to your question, and I'd be happy if you ask me that question. I can tell you more about formulas. But we understand how important that is, because what we want most is to make sure that the people that we are ensuring are getting the care that they need. With that, I'm going to yield my 7 seconds and urge your favor with amendment report.
Madam Chair, Madam Vice Chair, members of the committee, Dana Kaufman here on behalf of MedChi. The amendments that we have are the ones that were put forward by the sponsor, but it would be remiss if I did not also address this other issue that I think is a critical issue in the state of Maryland, and that is our payment rates. The reason that there are non-participating providers, we really have to look at that issue and ask, why? Why do we have providers who are non-participating? And I will tell you, if you get a room full of physicians in the room, they're going to say that Maryland's payment rates are too low. There was a study done in 2020 by the Healthcare Institute, and they listed, when they compared Maryland's commercial market to the Medicare market, we were third from the bottom. The only 2 states that were below us was Delaware and Alabama. We are continuing to see providers leave the network when they can. Sometimes carriers, their coverage is too large that we can't leave the network. But I did find it interesting when I was looking at a recent report by the Maryland Healthcare Commission. It noted that there were 15,627 in-network contracts were terminated across all specialties. 14,910 of those contracts were terminated by providers, and only 717 were terminated by insurers. And I think we need to find out why those contracts are being terminated. We have in the past seen letters being distributed to patients informing them that they will no longer in their physician practices accept certain insurers. Just recently, University of Maryland put out a letter, a very large practice, to their patients saying that they will not be able to continue to contract with a certain carrier. That is the question that we have to address so that we can ensure that we have adequate networks. Thank you.
Madam Chair, Matt Celentano, I was signed up opposed. I think that was probably just reflex.
This is why your friend here called you to come and join this panel.
I was going to apologize to Dana for calling her old in the earlier bill until she did that testimony. But, so no, I just wanted to say thank you to Delegate Sample Hughes. She was kind enough to bring us in, and we got to sit down with the advocates to talk through some of the issues. And I think with the amendments, and I just got them before the hearing, I have to pass them around, but I think it's heading in a direction where we can get to be able to say yes. So thank you for the time.
Thank you for coming forward. That's why you have friends. All right. So Delegate Hill.
No surprise. Thank you.
No, it's okay. Go for it.
I guess this is to you, Ms. Kaufman. I think you know something about the work we've done in this dental space. And we had a difficult time getting children who needed anesthesia in the dental space, and we looked for root causes. And if you don't, maybe someone else on the panel can address it. And I think we ended up deciding that the anesthesiologists and anesthetists taking care of children for the dental procedures just weren't getting reimbursed enough. And I guess the question is it that same kind of analysis that we look at root causes that you're asking us to do in not just this behavioral health space, but in the broader healthcare space to help us solve a lot of our adequacy and inadequacy problems?
I think we have to look at it in the broader healthcare space. Now, I do know of those numbers that I quoted from the Maryland Healthcare Commission report, and I'm going to probably fluff a little bit of these numbers, but it was about 26% of those contracts that were terminated were in the behavioral health space, but then about 7 of them were in the internal medicine space. So I think it does cross all specialties, and I do think we need to really take a look at some of those root causes, because I do think that we're starting to see an increase and terminations from provider contracts because they just can't continue to cover their costs within networks.
You're welcome. Any other questions?
Seeing none, thank you very much for your testimony. I appreciate it. I'm going to call my friend Ben Steffen and Laura Willing and Courtney Bergen and James Gutman. Will you be so kind and come up? And then after those witnesses, we are going to have three virtual ones favorable, okay? And Ben, you can get started. And before Ben gets started, Ben is going to be retiring in March. And he has been a real good friend of this committee and many of us, and always available when we call him. And it doesn't matter whether I call you on a Saturday, Sunday, you're always there. And I want to thank you on behalf of this committee, Ben, for all your years of service and for being caring, for being thoughtful, for being responsive. And we really appreciate you, and to let you know that our doors are open to you always. So we don't have flowers, but we're all giving you flowers right now, okay?
Thank you for the kind words. Undeserved, but thank you very much.
You deserve them.
I want to, first of all, it's always a pleasure to appear before the Health Government Operations Committee, and this may be my last time, and I'm going to say the Healthcare Commission, hearing what some of the stakeholders said, we're happy to step aside if that's the will of the committee. I would note, however, that we did recently do a network study on a related but not identical issue that looked at the comparability of the out-of-network payment formula for HMOs and the out-of-network formula for PPOs, and concluded that the PPO formula was more favorable to providers. That is something that I think we would have suspected. But what I did note is that there didn't seem to be any out-of-network payments for psychiatrists, clinical social workers, and so I think a question would be, there should be minimally a reporting requirement for the payers. If they have these formulas, how many people are you actually reimbursing under these elevated rates? Because the claim data we receive, which includes all fully insured products, as well as state and local self-insured products, they're not, those products are self-insured, but they're not covered by the ERISA protections that govern privately insured, self-insured companies. So we got a pretty big sample, and we didn't see much of anything in psychiatry, clinical social work, et cetera. So I think that we're happy to step aside. I want to emphasize some of the points that Dana made. That report, thank you, Delegate Bagnell, for the work on the behavioral health workforce assessment, a big gap. The stakeholders got that right. But a more important, compelling point is that we train quite a few mid-level behavioral health folks that can't stay in the profession because reimbursement is not adequate. Of equitable non-par rate is not going to solve it. The major recommendation of that study was elevate reimbursement for behavioral health providers. It has to be done more broadly than simply out-of-network payment rates. Thank you very much. It's a pleasure to have served you, and I'm going to miss all of the, well, not almost all of the committee members.
Because I consider you an expert, so I am going to call you now and then, and my door, as I told you, is opened, okay?
Thank you.
Thank you. We were very blessed to work with you. Who's next?
Good afternoon, Madam Chair, members of the committee. My name is Courtney Bergen. I'm an Equal Justice Works Fellow at Disability Rights Maryland. I'm also someone who lives with a mental health disability. DRM supports House Bill 11 because these protections are crucial for our clients to be able to access essential mental health care in the community. But this bill isn't just about my clients. This is something I've experienced personally. Back in 2019, I contacted more than 50 providers after getting out of a hospital. Not one in-network provider would work with me. It was only after testifying at a bill hearing here in 2019, my first time ever, that I was able to get any coverage. But unfortunately, less than 6 months later, that my insurance changed. I had to redo the whole process again. It resulted in a 4-month-long hospitalization while that contract was being renegotiated, and that hospitalization cost my insurer $135,000, far more than the cost of paying for outpatient therapy 3 times a week. But because and at the time, this bill wasn't in effect that we now have now and that will soon be sunsetting. The authorization my insurer gave me was going to cost me more than going out of network under their plan to use it because there was no balance billing protections. So I was going to have to pay their set rate and then the difference between my provider's billed rate. I was then able to, negotiate, with help of a lot of advocates who've testified here today, finally get coverage, go back to law school, graduate from law school, and when I graduated in 2023, returned to work, my insurance changed again, but fortunately I didn't run into that same problem because of the bill that was passed by you all back in 2022. So I would really encourage that you support House Bill 11 because these protections are crucial for people like me to live in the community and remain in the community. It's often the only way we can get the support we need because reimbursement in the state is just not commensurate with the time, dedication, and experience it takes to treat people with more complex needs. So I appreciate you listening to me, and I urge you to support this bill. Thank you.
I can do it.
We appreciate it. Who would like to go next?
I can do it. Good afternoon, Chair Pena-Melnick and members of the HGO Committee. My name is Jim Gutman. I'm a Columbia resident and a lead healthcare advocacy volunteer for AARP Maryland, which has 850,000 members. We're here today to voice our strong support for HB 11 and thank Delegate Sample Hughes for all her work on it. You may wonder why this is such a big issue for AARP Maryland. On the surface, this looks like an issue for commercially insured people. But there are many answers to this question. Number one, AARP Maryland represents people aged 50 and above, so we get a lot of the commercially insured as well as the people on Medicare. But also very directly, this is an issue that many seniors are facing themselves, the ones who are 50 and over themselves who are looking for care. Very often they're on very limited fixed incomes and they have problems affording and finding providers to treat them. And that's just one part of the issues that they face. The other part is when they're 65 and above and they have behavioral health problems, not only do they have problems affording care and finding care, but they also may wind up in the emergency room, as many people under 65 do as well for behavioral health issues. This has been a real problem once the pandemic got started and accelerated trends in effect long before that. And the problems with shortages of behavioral health providers and not being able to afford behavioral health has a direct effect on the ER overcrowding in Maryland, which, as you know, is one of the worst in the nation. So this is another issue why it's real important for seniors. Another reason is that many older residents face unique behavioral health challenges. Not that others don't have them, they just have them more often. Depression, anxiety, very prevalent, and often compounded by isolation and chronic health conditions. These are all factors that lead AARP to see this as a major issue, and we'd urge you, we'd appreciate and urge a favorable report. Thank you.
Welcome. Before the next witness testify, you're next, correct? I have to step out to meet the chair of Judiciary, so my vice chair is going to take over, okay? It's not a sign of disrespect to anyone. And there's 2 other virtual witnesses, actually 3 left as well. Delegate, this bill will go to subcommittee, and you're welcome. Please come to the subcommittee when we have it. And anyone else that you would like to bring with you, okay? And bring the friend of Ashanti with you as well. All right, go ahead. Go ahead, ma'am.
Thank you. Chair Pena,
Melnick, Vice Chair Cullison, and members of the committee, thank you for the opportunity to provide testimony in favor of House Bill 11. My name is Dr. Laura Willing, and I am a psychiatrist at Children's National Hospital. Nearly 60% of Children's National's patients are residents of Maryland. Children's National strongly supports House Bill 11 because we care for many children and adolescents from Maryland who have great difficulty finding appropriate mental health providers within their insurance network in a timely manner. I have seen children in the emergency room who haven't been able to connect with an in-network therapist and are waiting on multiple wait lists. I have cared for teenagers admitted to the hospital whose families have struggled to find outpatient mental health care covered by their insurance plan. I have seen many youth in my outpatient clinic who work for months to connect with a therapist in-network. These are just a few of the many examples of how this bill will help families and patients access care and reduce unnecessary suffering. In addition, House Bill 11 will prohibit the use of prior authorization as an additional barrier to getting out-of-network care. If a patient's family does finally find a mental health provider with availability, it is important that they are able to access care quickly without additional barriers to care for the family and without additional administrative burdens for the provider. We know that in Maryland, many insurance plans do not have adequate mental health networks, and that often these networks are even worse for children and adolescents. Several studies have shown that Marylanders go out of network far more often for mental health and substance use care than for medical and surgical care. We need to decrease barriers to accessing this care for patients and families and decrease disincentive for providers to participate in networks. Thank you for the opportunity to submit this testimony.
Thank you for being here, for your patience this evening. Are there questions for this panel? Delegate Rosenberg.
What advice will you be offering to your successor that you can share with us?
So there's a lot of, the Healthcare Commission touches a lot of the issues that come across the healthcare system in Maryland. We try to do that collaboratively, but oftentimes we need to forcefully engage stakeholders. I think I would tell that person, not to be afraid of angering any group. Tell it like it is, and remember that oftentimes we are in legislative matters dealing on a transactional basis, and that an issue that people are strongly opposed to may yet hide an issue that we can all work together on. When I was little, my father, I can't remember exactly what he said, but he said, you have to look out for the underdog. And I think this committee, whether you're Democrat or Republican, has had that as a mission. And I would really encourage you to continue to take that as an important guiding principle as you move through this session and future sessions. That I can't think of a committee in the Maryland legislature that doesn't hold the principle of looking out for underdogs more closely to the heart than this committee.
Thank you very much.
Thank you, Delegate Rosenberg. Delegate Taveras.
Thank you, Madam Chair. I guess I have a question for Ms. Laura Willing. Yes, I feel like we've been together a lot today. So I have a quick question on, you're seeing that it's very difficult to place children that have behavioral needs in because of a lack of beds, or why? And have you all considered, or when have you considered treatment out of state for a particular child?
Thank you for that question. That's a good question, which I was in my testimony just referring to patients trying to get outpatient care. out-of-network, but inpatient care is also difficult to find, and there are not enough beds in Maryland for children and adolescents, and we do sometimes ask for authorization to look out of state for beds when necessary. And certainly in Children's National, we have a lot of patients from Maryland in our inpatient unit.
Okay, Delegate? Okay. Delegate Woods?
So my question is, the children that you have, are they part of the DSS system? I'm gonna get it right.
Thank you for that question. I do not have the numbers in front of me, but I believe some of them are.
Madam Vice Chair, so when they're not a part of the DSS system and you talk about the possibility of taking them, sending them out of state, who then becomes responsible for them?
So if they have commercial insurance, we would be looking for we would look for a prior authorization for where we could send them if it was out of network.
Okay, and is it safe to assume, am I okay? Thank you. Is it safe to assume that that has to come with parental consent?
Yes.
Okay, thank you.
Any other questions? Then thank you all very much for your time and your testimony and your patience and perseverance today. We have 3 virtual witnesses. We'll take one at a time. Let's start with Shannon Watch.
Shannon was here earlier.
She's not here. Laura Mitchell? Okay. Ms. Mitchell, please take yourself off mute. Oops, we lost her. There we go. And thank you. You may start.
Thank you. Vice Chair, I was trying to make sure I had the live stream muted so it didn't squawk at you.
Thank you for that.
Apologies. I'm Laura Mitchell, a longtime advocate for mental health and substance use care and treatment and prevention. And that comes from family experience with my child and now with my grandchild. And for 2 years, my family struggled to get the multifaceted mental health treatment that my granddaughter required. And that struggle very nearly cost her life. She was hospitalized because we were not able to get that care. It got to the point that she was suicidal and had to be hospitalized for a 3rd time. And even our provider could not help us find care in network that would fit her needs. She's on the autism spectrum. She's had multiple traumas. There were a lot of factors that went into that. There were no inpatient residential treatment centers in Maryland that could help her. We were looking at Atlanta, Colorado, and other places that were far away. It's very hard to heal a family and help a young person heal and grow when you're not anywhere near them, when you're thousands of miles from them. So that was not acceptable. We finally found care for her out of network, and this bill enabled us to be able to utilize that service. And it has turned her life around. She's now a senior in high school, and I look forward to her graduation instead of dreading, is she going to make it through? And what do we do next after that? There are a couple of issues that have come up with this. Number one is that the insurers still misprocess the claims each time, despite putting in big bold letters that this is an inadequate network exception, their words, and the case number, it still gets processed as out of network. So in addition to the $2,000 I pay for premiums each month, I'm having to pay another $1,000 each or more for her care and wait to get reimbursement when they're only reimbursing at an out of network price. That is very costly. And the authorization every 6 months, I wake up in the middle of the night, oh no, she has an appointment tomorrow. Is it time to reauthorize? Did we do that? it causes a lot of stress for us. Those things need to be corrected, but we absolutely have to continue this. Her life and many others depend on it.
Thank you very much, Ms. Mitchell. Are there questions of this witness? Seeing none, thank you for sharing your story. It means a lot to us to be able to understand the impact on folks. And the last witness is Stella Hong. Okay. Ms. Hong, go ahead and take yourself off mute and begin.
Good afternoon, Vice Chair and committee members. My name is Stella Hong, and I'm a senior at Johns Hopkins University studying biology. I'm here to express my support for House Bill 11, which helps Marylanders have access to necessary care. Because I'm a pre-dental student, I want to share how this bill will affect Marylanders' equitable access to dental care. The Maryland Department of Health Office of Oral Health conducted a survey that highlights persistent oral health challenges amongst Maryland school children. The surveyed 4,950 children in 14 school districts, and their key finding was that 1 in 3 children from the lowest economic group had untreated decay. One of the policy changes that the Maryland Department of Health urges is the enhancement of Medicaid reimbursement rates for dental services. On page 5, lines 1 to 3, of this bill direct the Maryland Healthcare Commission to establish a formula that sets fair reimbursement rates for non-participating providers. By doing so, the bill ensures that specialists who step in to provide care are fairly compensated, encouraging more providers to accept out-of-network referrals and expanding patient access to care. The House Bill 11 removes unnecessary to care by repealing the termination date for provisions that allow patients to seek referrals to out-of-network specialists when no in-network providers can meet their needs. This bill is particularly important for those seeking treatment for complex or long-term conditions, which include many mental health and substance use disorders. Without safeguards such as this, patients may face significant delays or be forced to settle for inadequate care. No one should have to fight through layers of insurance hurdles just to get the care they need. And I respectfully urge you all to for a favorable committee report. Thank you.
Thank you very much, Ms. Hong, and best wishes to you in your studies. We're very glad that you are going to be, and we hope that you are going to stay in Maryland when you graduate and become a dentist here in Maryland. I'm not sure if you heard the initial part of the hearing, but the part of the bill that requires the Maryland Healthcare Commission to look at reimbursement rates is going to be taken out for this bill. However, we have acknowledged in this committee today that it is a significant issue and that we do need to follow up, and your testimony is very timely in terms of those considerations. It's probably going to be something that we're going to be studying before the next session, and I hope that you'll watch our bills next year and see if there's a follow-up to this. In the meantime, is there any, or do any delegates have a question for Ms. Hong? Seeing none, thank you very much for your patience today and staying with us, and for your advocacy for on the payment rates for our providers. I appreciate it. That is the last witness for this bill, concludes the work on the bill and the work committee today. Committee members, please remember that we have a voting session tomorrow at 11:30. It is in person, and then we have a briefing tomorrow afternoon, which I believe is at 12:30. So have a good evening, and we will see you tomorrow. Thank you.
Say that